Good afternoon. I'm Senator Gary Daniels from District 11. Today we'll be holding a meeting of the Senate Finance Committee. Before we get started, I'll read through a checklist to ensure the meeting we are holding is in compliance with the right to know law. As Chair of the Senate Finance Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic, and in accordance with the governor's emergency order number 12, pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I'm confirming that we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and/or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. We have provided public notice of the necessary information for accessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate@leg.state.nh.us or call 603-271-6931. In the event the public is unable to access the meeting, it will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done by roll call vote. Finally, let's start the meeting by taking roll call attendance. When each member states his or her presence, please also state where you are and if anyone else is in the room with you during this meeting, which is required under the right to know law. I'll call roll. Senator Rosenwald.
Good afternoon, Cindy Rosenwald, District 13. I am present in the Senate chamber with all of you.
Senator Gaida.
Senator Bob Guida, District 2, President of the Senate Chamber.
Senator Reagan. Senator D'Alessandro. Senator Hennessy.
Aaron Hennessy from Littleton here in the Senate chamber.
Senator Morse.
Senator Chuck Morse, I'm in the Senate chamber.
And I'm Senator Gary Daniels, and I am in the chambers as well. I would now invite you to join me in the Pledge of Allegiance.
Pledge allegiance to the flag.
Our first presentation this afternoon is with the Insurance Department.
Do I go?
Good afternoon.
Good afternoon. Can you hear us?
Ken.
Perfect. For the record, my name is Chris Nicolopoulos. I'm the Commissioner of Insurance. I'm joined today with three of my staff members. I've got DJ Betancourt here, our Deputy Commissioner, Theodore Ted Perkins, our Director of Business Operations, and Norma Stallings, our Director of Tax. I first of all want to thank you for the opportunity to present our 22-23 budget for the New Hampshire Insurance Department. As you'll see, our 22-23 budget of $12,800,000 and for 23, 13 million, roughly 400,000 are basically flat with our 2021 budget of 12,900,000. I'm going to break these budget expenses into four primary categories. And the first one will be employee expenses. Given that the department has 69 classified employees and 16 unclassified positions, the vast majority of our budget is made up of these employee-related expenses. Those include Class Code 10 of 4.9 million for our classified employees, Class Code 11 of 1.588 million for our unclassified employees, Class Code 60 for 3.2 million, that's related to benefits, Class Code 64, 240,000 related to retirement, And then in county unit 2521, we've got class code 10, 200,000 for classified employees, and class code 60, 97,000 in benefits. So in total, those employee-related expenses total $10,344,600. The next largest group of expenditures for our department are mandatory transfers to other state agencies. Those transfers include class code 27, DOIT for $610,000, class code 28, rent, $267,000, class code 40, SWI cap for $259,073, class code 49, which are transfers to the Attorney General's office and Employee Assistance Program of $90,000. And finally, in that category, class code 89, our DAS maintenance fund, a charge of $22,000. That group totals $1.249 million, leaving roughly another $1,200,000. That's made up in group 3 of class code 46, which is consultants. That's a $399,000 line. And you'll see that there was a $108,000 reduction from our 2021 levels in this line. In class code 102, which is contracts, those are contracts related to required state services, $320,000 in our budget, and that represents a $170,000 reduction. In these two categories, we cut nearly a third off from our 2021 levels. And this is a concerted effort on part of the department to use our staff when possible to deliver these key services. But because all of these services in these two groups are legislative mandated reporting or roles the department plays, we sometimes need to bring in expert consultants to help us. And these would include things like our qualified health plan process, which certifies the Obamacare plans or the ACA plans here in New Hampshire. Finally, the last couple $100,000 of our budget are administrative office expenses, and that includes everything from paper to copy machines, travel, books, and dues. Finally, as a reminder, the New Hampshire Insurance Department is a self-funded entity. We raise our revenue by charging an assessment on regulated entities, and our budget has no impact on the general fund. Finally, while I have the floor and before I entertain questions, I wanted to talk about two things that we didn't know at the time when we presented the budget. The first of those is we recently started our once in a 10-year cycle LBA audit. The LBA audit is underway. We anticipate that will close sometime in early fall. As part of that process, we've been told that we should expect a $160,000 bill from the LBA. As a self-funded entity, we are required to cover the cost of the LBA audit. And we would ask that you'd consider putting that money back into our budget so that we have it available to pay for the required audit. And finally, as part of a reorg that happened over the last 3 or 4 months, we created a new position as Director of Life and Health, which is half of our staff falls on the life and health side. And we have a parallel position that is a Director of our Property and Casualty business. As part of the process of reorging, DOP recommended that we take those 2 level 35 director level positions and make them unclassified based on their SJDs. DOP believed that we were best suited to transition those 2 unclassified roles and to go through that process. If you're willing to entertain that, we will provide you with language for HB2 that would facilitate that process to move forward. Other than that request, we have no language that we would need in SB2. We're not asking for any new positions in this budget, and things are good at the department.
Thank you, Commissioner. Any questions? Senator Hennessy.
Thank you, Chairman, and thank you, Commissioner, for taking my question. Just looking at the total for your entire department compared for 22 compared to fiscal year 20 actual, there's a 21% increase. Is there something that you weren't able to do in 20 that you normally do?
Senator, that's a phenomenal question, and I anticipated that question because it was a large decrease. Over the last 18 months, our department is undergoing a transformation of sorts as some of our more senior staff make decisions to move on to retirement. And as that happens, we've had more than we would like staff vacancies. That was exacerbated some by COVID even into this year, but the vast majority of those unspent funds were staff positions that were not filled. Part of the reason we're able to reduce those contracted services is we are training and bringing on folks to fill the rest of those spots. And for all of our open spots, we are currently actively looking to fill them.
Follow up?
Just to follow up. So if those staff positions were not filled in 20, were there things that the department was not able to do because they didn't have the staff to do them? Or, and put another way, do you actually need to fill those positions?
I've only been, well, I'll be honest with you, I've been in the department now 14 months. So the things that might not have happened in 20 were before I was here. Our department has met all of our critical functions through 20 and 21. These, I believe virtually all of our open spots should be and need to be filled. Part of that is because our team is probably more expert, more expert level and trained level staffing than you might see at a typical state agency. It's critical that we continue to train the next generation of our team here. And so I do believe we should and will fill all those spots, but I don't think anything fell through the cracks in 2020.
Thank you.
Further questions? How many vacant positions do you have now?
10, I believe. And we're interviewing for 3 of them right now.
Okay. Are those 10 positions currently funded?
Yes.
And how long have they been vacant?
One of them yesterday, one of them last Friday. The oldest one is over a year. So I think that's the range of.
Okay, thank you. Senator D'Alessandro.
Thank you, Mr. Chairman. Commissioner, in looking at your budget, between the governor and the House, there are no changes. So what was the ask that you brought forth for that audit?
100. So, Senator, thank you for clarifying that if I wasn't clear. We learned that the audit would happen after we presented our budget to the governor, and we learned the number after we presented to the House. And so that number we are told is going to be $160,000. And so that is a number that we would like to be added in at this step of the process.
Follow up?
So, but other than that, you have no ask.
That's right.
Thank you, Mr. Chairman.
Good thing. Any further questions? Seeing none, thank you very much, Commissioner.
Thank you.
Have a good day. Next up, we have the Office of the Child Advocate.
Good afternoon. Can you hear me okay?
Yes, you can.
Thank you so much. For the record, my name is Moira O'Neill, and I am the Child Advocate running the Office of the Child Advocate. And also with me in the background is Karen Kimmel, who does most of our budgeting work and will help if you have questions for us. Thanks for the opportunity to provide updates on the status of the Office of the Child Advocate and explain our budget needs. We do appreciate the difficult task that's before you. With your permission, I'd like to just provide a very brief update for the purpose of context for your budget decision-making.
Okay,
On September 28th or 18th in 2020, so just about 6 months ago, RSA 21V went into effect, considerably expanding the office's jurisdiction and mandate. So in some ways, we are an all-new office again, 3 years into the office's existence. We're now responsible for oversight of all children's services provided by or through arrangement of state executive agencies. That includes, but is not limited to, child protection, juvenile justice, behavioral health, developmental disabilities, early supports, and education. The office meets its mandate in essentially 4 main roles, and I'll just be quick with this so you have a good sense of this office. First, we review children's services and their care, and that includes receiving service complaints from constituents, that may children, families, even sometimes people working in the agency and the providers, working with the agencies to resolve complaints, visiting children in care and assisting them when they need it, and reviewing and monitoring critical incidents that involve children who are in state care. So to give you a sense of that, in reporting year 2020, we processed 312 complaint cases and 2,183 critical incidents that included 18 child deaths. We're now just halfway through this reporting year with about 200 complaint cases and over 1,100 critical incidents that include 13 child deaths. Another role is to review and collaborate on program and policy development. This includes participating on committees, working groups, advisory panels, providing system input. We've been deeply involved in the probation transformation project, for example, and as you know, carefully analyzing situations like the closing of the Sununu Youth Services Center. A third role is, as the statute requires, is that we regularly consult with and advise on all of these matters, informed by the complaints and the reviews that we receive and do, in order to advise the governor, the legislature, agencies, and other public systems in the best interest of children. And then the last role, which is all equally as important, is that we provide outreach and education on state systems. And that includes providing children and other constituent information and referral services, assisting with system navigation, and perhaps most important, disseminating information about research findings and practice standards so that the state is ensuring that they're providing the best we can for children. So in the packet that I sent you, I provided you with a healthy list of, to demonstrate the workload of the office. And if you have questions, I'll save the time of going through that, but if you have questions about them, I'm happy to take those. One thing that's not reflected there, we're very excited that we just received a grant from the New Hampshire Charitable Foundation to secure services for a consultant to walk us through a 5-year strategic plan for the office. I think having been in existence for 3 years now with substantial mandate changes, each year we're busier. This is now the time to really set a course for this office to be most effective and efficient. So that's the background of how the office operates. You asked us about differences in the fiscal year 20 actual budget and the 21 adjusted authorized budget. And you should have a graph before you. If you need me to show one, I can. The biggest difference was in personnel services. In the original ask, we had requested for, I think the actual was around $8,466. We ended up authorized for the fiscal year 21 around $15,000. What that reflects is that we have a temporary legal aid position, and there was a gap in that position being filled. So this is not a big budget. So I'm sure that that's probably kind of adorable for you to think about this small amount of money, but we use it very carefully. We also had some changes in employee training, which reflects, number one, the expansion of the mandate and the need for us to understand what we're overseeing. And also we did have a new employee. Then promotional and marketing materials had a little uptick in the difference in what we're spending because we're communicating a lot more with children who are in residential programs through marketing materials, making sure that they understand who we are and how they can get in touch with us. And we saw a difference in state travel reimbursement and out-of-state travel. Originally, it had been a priority for the office, somewhat requested by legislators who wanted us to make sure someone was checking on children who have been placed in residential programs out of state. And unfortunately, because of the COVID interruption of everyone's activities and the inability for us to access children, we didn't spend quite as much as we did. And we anticipate as the restrictions are lifting, we're going to be out in the field and visiting with children as soon as possible. Then the next question, I think that you were asking about differences in the FY 22-23 budget reflecting what we requested versus what we approved in personnel funds. Like the Department of Insurance, the bulk of costs associated with this office are staff, an invaluable resource. We requested a full-time legal aid, and the governor's recommended budget, it was approved for a part-time legal aid. And that legal aid would assist with data entry and management as a means for us measuring compliance with standards for children's care and reporting. We also requested a second full-time assistant child advocate, which is a position that processes and reviews the complaints that comes in, works with the children in the field, and assists with preparing reports. The other request that we had that did not make it into the budget was funding for a case management system. We were part of a pilot of the Salesforce enterprise system that's been rolling out across all of the executive agencies. Because we were the first pilot and we were so small, we sort of experienced the classic we learn as we go sort of a situation. We ended up with a database that is not necessarily useful for producing the kind of data that we need in terms of measuring the performance of state agencies and our office. And we haven't been able to get the technical assistance we need to be able to make the changes to make it more useful. So we have identified a software that was actually designed for oversight offices like ours, and we had requested funding for that, but that didn't make into the budget. And we also made a request for a state vehicle to save money on what we are spending on reimbursing individuals for using their own cars. And I think those are the major differences. In general, we're fairly well supported compared to other agencies. I know there were a great deal of cuts in areas, but I'm happy to take your questions if you have some.
Thank you. Are there any questions? Senator D'Alessandro? Hey, you want to put on your microphone, please? Thank you.
Thank you. Thank you, Mr. Chairman. You mentioned the grant from the Charitable Foundation. How long is that grant for and how much is it?
Thank you. Thank you for that question, Senator. That grant is $27,000. It's specific to the project of hiring consultants for this, just for the purpose of doing a strategic planning. And so that the money is good just for the duration of the project. It covers the cost of the project.
Okay, so you said the grant will last for the duration of the project?
Yes, and we assume it will take 6 months for that to be completed. But that's going to fiscal right now and then GNC for approval.
And in looking at the budget, obviously there is very little change in what the governor recommended and what the House approved. What was your ask for additional items based on what I see before me?
The ask, thank you for the question. Do you mean what were the items, or do you mean the number, the amount of money?
Well, first of all, the items and the dollars associated with that would constitute would it constitute a significant change in the appropriation?
Okay, so I'm gonna list out what the items are while Karen adds up that total. So the items were, rather than a part-time legal aid, a full-time position, a second position for the assistant child advocate, and the state vehicle and the case management system. And the total for that would be,
The personnel cost should be about 80,000 plus benefits.
so that's 80,000 for personnel costs.
And then for fiscal year 22, for the case management system, I believe setup and administrative costs are maybe about $30,000.
30,000 and the
For fiscal
card
year
is another,
23, we were looking for the 20,000 for the vehicle and another 15 operating costs for the case management.
15, so that's
35.
so that's, what is it,
Another
130?
35.
Another 30, so, yeah, another 35. So the total is 110, 130, about $160,000. Is that right? I'm sorry, 80? I'm sorry, 1,000 plus 30,000 is 110,000. And then 130,000, so $160,000.
160,000, okay.
Yes.
Gotta go.
In order to answer, in order to, respond to our wish list.
Right, okay, and just so that I have it correct, Mr. Chairman, the ask would be the legal assistant, and a child advocate and a vehicle,
And
correct?
And a case management system, Senator, thank you.
Okay, thank you very much. Thank you, Mr. Chairman.
Thank you so much for your questions.
Senator Rosenwald.
Thank you, Mr. Chairman. There's been a lot of discussion about the Sununu Youth Center. And the House put in a drop dead closing date of July 1st of next year and left, I think, $2.5 million out of close to 14 million in the budget to plan. I'm just wondering what your thoughts are on what we might need to replace that facility with the right-sized secure setting, and what other kinds of services to best manage and treat the children that are entrusted to us.
Thank you, Senator, for that question. And that's a very important conversation that's been happening. We have released, and I believe I sent to you all an issue briefing with some things to think about in terms to answer those questions. I think it's important, first of all, to keep in mind that for the past number of years, the state has determined that children are deserving of us investing anywhere between $12 and $15 million a year to maintain that facility. So that has been an investment in children. And so now the impetus to close the facility is based on two schools of thought. One is to save money, which is very reasonable because the building is empty and it's very expensive. And two is to do what's best for children. And it's very evident that it's not working to incarcerate children in the way that we are. And so what I would suggest is that 12 to $15 million that we have committed to children in the past for a building should actually be considered as an investment for children going forward in programs that work better. So I realize that the political expediency of leaving that much money on the table for children may not be as palatable as most policymakers would like. But I would think the optimal option would be to have at least about $10 million set aside to figure out what the residential secure bed needs are, which will likely be less than 12 beds. We estimate it's probably much less than that, but it may be difficult for people to believe that. It all depends upon the rolling out of a number of programs, services that are on paper right now in New Hampshire that will replace and prevent the need for secure settings for children. And additionally, what we would propose a good chunk of that money be used for is building out the strengthened communities so that people like law enforcement officers and parole officers and the courts even can feel confident that the communities can support children, prevent delinquency, and also that communities can feel safe. And so, we have proposed using some of that money to secure or create some secure beds for children, no more than 12, and also to create a regional granting incentive granting system so that communities can compete for grants to build out their diversion programs and other supportive community services like mentoring, after school programs, memberships for the YMCA, job coaching, and help supportive employment, those sorts of things. We know that the rest of the country is watching New Hampshire because we've really started building out a system that will be very responsive and developmentally appropriate. And so the decisions with what we do with the resources that are currently being taken up by the Sununu Center will be watched very carefully to put us right at the top of things. So I hope that's helpful and answers your question. We look forward to working with folks to come up with a good solution.
Thank you.
Senator Gaida.
Thank you, Mr. Chairman. Maura, under the case management system, is your agency in any way associated with the Unite Us system, the closed loop data system that HHS is implementing?
Thank you for that question, Senator. No, we are not. We have separate access to the DHHS, what's now called the Bridges system. But our data management system really needs to be separate from everyone else. However, right now it's part of the enterprise system that is the Salesforce platform that's being rolled out in all of the state agencies. There's been a delay in that because it's also being used right now for the COVID response. But we were looking for, actually, it's essentially an off-the-shelf small system that would help us manage cases and also allow us to be able to report data analysis to folks like you in a much more efficient way. And it's designed specifically for these kinds of offices that do oversight and have case management.
Follow up. So as I read your paragraph in the document you provide, you're going to try to get away from the Salesforce system, get into your own system.
Yes, we are. Thank you for that question. I have to say that the Department of Information Technology has been really, a super agency, especially during the COVID pandemic. But because we are so small, we are not a priority. So our system was set up on the Salesforce system platform back in around October of 2018. And it was done in a rushed way as people were learning how to set it up and how to use it. And so we ended up with really an incomplete system. And since then, we have not been able to get technical assistance to make the necessary changes that we need. And it's very clear that going forward, we're too small to be a priority agency. And it's going to take several years for all of the rest of the enterprise system to roll out. And so we're really essentially non-functioning, other than to keep cases, have a place to store things. We're not really able to generate any useful data.
Follow up.
Thank you, Mr. Chairman. On a different subject, over the past couple of years, it had been brought to light that the relationship of HHS working with you as a child advocate was less than desirable for the benefit of the kids. Has that been remedied?
Thank you for that question. I have to say, I haven't actually heard that. We've had a very good relationship with the department. We have a review system, a case review system that's based in safety science that actually facilitates reviews with DCYF employees, and that has generated a very good relationship and also generated a lot of improved work performance in the agency. We often get feedback from the agency that's very positive as well. And we work pretty closely with all of the constituents who call us. It's very rare that we get a complaint. And so if you have complaints about the Office of the Child Advocate, I would really appreciate if you would share them with us, because obviously we can't remedy anything that we don't know about.
May I follow up?
Follow up.
Maura, the complaints are not with your office. The
Oh.
complaint is with the cooperation of other, specifically HHS and potentially maybe the courts, I don't know, but there was some talk about you having difficulty being able to perform what we've asked you to do for us.
Oh, okay. Thank you. I'm sorry for that misunderstanding. The way I heard you was different. I will say that it was a while, in human nature in general, no one likes being overseen, having someone look over their shoulder. And that's why we've worked really hard with the safety science to try to do this in a sensitive way. So we've got a good working relationship going with DCYF. In September, when we expanded our jurisdiction, and we had to make our way into understanding the rest of DHHS, we did reach a great deal of sort of slow response. And in fact, had to consult with the Attorney General's office in order to get to assure the department that we actually have the jurisdiction to access things like the names of leadership and their phone numbers in the department so that we can contact them, our requests for data and information. And so now that is starting to flow. And fortunately, Director Ribson at DCYF and our office have sort of modeled a very good working relationship with regular meetings. And so we're starting to get people from HHS to reach out and set up meetings with us too, so that they can see the benefit of it. There was resistance certainly in the beginning. I'm seeing that that's starting to work its way through.
Thank you very much.
Thank you.
Thank you. Further questions? I have a couple. On your chart of the fiscal year 20 actual versus fiscal year 21 adjusted, one of the things you noted on there was number 2, promotional/marketing.
Yeah.
And the statement says the office experienced an increased completion and distribution of reports and communications for children in the custody of the state. What does that mean?
Thank you for the question. So by reporting, it means that we probably printed, so we released several public reports in that year. And so that would be printing costs for some, although we don't print very much anymore. I would say the bulk of the costs was in materials that we created and distributed for children, specifically those in residential care. We have posters. And we've provide other kinds of communications with them, information about what their rights are while they're there and how they can contact us. And particularly as the pandemic rolled out and children were not visited in person and people weren't seeing them, we thought it was really important that children knew that they had someone who they could come to for help if they needed it. And so that's largely what that cost was. By marketing, we mean communicating with our constituents.
Okay, thank you. And are your number of complaints and incidences rising?
Thank you for that question also. I would say they are, given that we're only halfway through the year at this point, and we're seeing already, I would say it's probably going to double this year.
So I guess my follow-up question to that is, what program is failing to address the issue before it gets going?
Thank you. That's a very good question. I would say that we have seen some shifts as DCYF has improved with more staffing, so we don't get quite as many calls anymore that people aren't returning calls, for example. I think a lot of the cases that we're seeing are more complex, and they are largely involving children who are in residential care. And we're about to see a shift because the department is working on contracts now. There's a redesign of how they do residential care. So we're going to be shifting over to monitoring those contracts to make sure that the care is reflective of what they're being contracted for. So I don't know that I would use the word failure, but I would say that there's a lot of work going on with meeting children's needs clinically. We've been getting a lot of calls, of course, you can imagine, about the children who are backed up in the emergency departments in their need for access for mental health crises. care. We worked very hard on Senate Bill 14 in 2019 that passed to expand all of these services at the community base, and they've been delayed in rolling out. So while we're excited that they're about to be launched in the coming year, there's a lot of children who are still waiting for those services, and it's very difficult to be able to find a way to patch services through until we have a good system of care standing up and operating.
Okay, thank you. Senator Gaida, another question.
Thank you, Mr. Chairman. Moira, you oversee kids in residential care facilities, in-state and out of state?
Thank you, Senator, for the question. Yes, we oversee any services that are offered to children or arranged for children by an executive agency. So that does include, and right now it's taking a lot of our attention, the children who are in residential programs in state and out of state. And where that's reflected in the budget right now is our out of state transportation costs, which currently we're not able to use. But just to give you a sense of what this means, when a child is placed out of state, generally they're visited, although children are supposed to be visited at least once a month. When they're out of state and a little further away, they're visited every 3 months. So that's 4 times a year. So we don't have, as a state, as a parent of children who we have placed elsewhere, we don't have a lot of eyes on those children. So it's our job to go and visit them as soon as we're able to. We also have this extensive critical incident review process where New Hampshire providers are required to report to DCYF when there has been an incident involving a child in their care. We don't get reports about incidents of children who are out of state. And I believe right now we have about 70 children
Jesus.
who are placed out of state that we're not carefully overseeing.
Thank you.
Thank you.
Sorry about that. Thank you very much for your presentation today. I see no more questions.
Thank you very much. And as I said, we very much appreciate the difficult task you have before you. And if you have other further questions, please contact me. Thank you.
Great, thank you. So at this time, we will move into Health and Human Services and recognize the Office of the Commissioner.
Good afternoon.
Good afternoon, everyone.
Yeah, maybe if you want to hold on just for a moment, because I think there are a number of people to be brought in. We'll wait till we get everyone.
Chair, is it okay if I go ahead and share my screen?
Yep.
Yes, go ahead.
Great, thank you.
What's that? Okay, could we ask you momentarily to not share your screen? It appears we can't bring people in while you're sharing the screen.
Sorry about that.
Learn something new every day. Okay, we're all set.
Okay, great. All right. I'll go right to this. Go ahead, Commissioner.
Okay. Thank you for the opportunity to speak to you about the Department of Health and Human Services. And although I'm going to give you an overview of our priorities for the coming year, the DHHS team, which will present after me and on Monday, will present very program-specific information and be able to answer your questions in more detail than I am going to address today. For the past year, the department's worked has been very largely focused in planning and executing the system of care for COVID-19. Most of you know that this has been a major undertaking by the department. We successfully stood up statewide testing, case investigation, contact tracing, vaccination, and PPE procurement. Our success around COVID-19 clearly demonstrates the capabilities of the department when we're able to clearly focus on our objectives. Although several other DHH projects were paused during the COVID-19 crisis, our teams have been very busy over the past several months putting everything back on the appropriate timeline. Some of the initiatives that you will see reflected in the budget, the ER boarding crisis. We have worked diligently over the last several years to not only identify the problem, but also be solution focused. We know the most therapeutic environment to receive care is in the community. And although we may need additional inpatient beds in New Hampshire, success is not having enough inpatient beds to eliminate the wait list. Success is preventing the crisis before the emergency room stay. We will focus our solutions in many areas to attempt to solve this problem permanently. By the end of the calendar year, we will file an IMD waiver from the federal government that serves as an incentive to attract private partners to the state to increase our inpatient capacity. The full procurement of the children's system of care, of which the OCA talked about during her presentation, it is well on track to be awarded in the coming weeks and months. That will ensure that we consistently assess and kids are placed in the system that meets their needs.
Commissioner, we have some members that are having a hard time hearing you. So if you could speak up a little and/or get closer to the mic, it might help.
Is this better?
Yes, thank you.
In addition, for ER boarding, the development of an inpatient forensic program to ensure that civilly committed patients can always receive care in a clinical model of care. And then finally, the initiation of critical time intervention, or CTI, which you will hear talked about during the Division of Behavioral Health and probably during the A&M presentation, which is an evidence-based program that works with patients recently discharged to prevent readmission. These are a few highlights around ER boarding. There are many, many more programs that Katja Fox and her team will get into as they present. Another initiative is the developmental disabilities. We are in the beginning phase of our transformational work on the DD waivers. The goal of the transformational work is twofold: to ensure that citizens with disabilities get the care based on their individual needs, and then also to make sure that we're providing a full continuum of care in New Hampshire. And as we just talked about with kids in the DCYF system or in the JJ system being served out of state, we also have people with developmental disabilities being served out of state because we do not have the full continuum of care in New Hampshire. So our goal is to bring that level of care back to New Hampshire. MMIS, or the Medicaid Information System, is going to take a forefront, get us up to date on our federal regulations, avoid penalties, and creating an environment that's more user-friendly. And then SYSC alternative, which is something that OCA O'Neill talked about in her presentation. I think we all agree that finding an alternative to youth detention is needed for the state of New Hampshire. We've done a lot of work over the last 5 years. 5+ years ago, our average daily census there was well over 50. We are now right around 15 juveniles on any day, on any given day. We're committed to putting a plan in place and bringing something before you in the coming months that puts an alternative in front of you. I don't think that we're ever going to fully get out of child detention, juvenile detention. Like the OCA said, I think the number is far less than even the 12, 15 that we have now, but we still need to provide a secure environment for that small group. These are just a few highlights of our program initiatives, and they'll be described in more detail. Before you is the agenda for this afternoon, and I'm just going to touch on the first couple of slides, and then I'm going to hand it over to my team. Next slide. So the missions and the responsibilities of the department. The overall mission is to provide for the basic health and human services needs of our most vulnerable citizens. We do that by not only ensuring that our healthcare providers provide safe, effective, and equitable care, but also by addressing the social determinants of health. These two things cannot be separated. Some examples of social determinants of health include having safe access to housing, having access to transportation for medical appointments, having access to healthy food. They are all intertwined together. You can't have one without the other. Obviously, if you're trying to take care of yourself and you have a disability or you have diabetes, if you don't have safe housing, access to healthy food, you are not going to be successful in maintaining a healthy lifestyle. On slide 4, we have 5 main roles in the department that are outlined very distinctly here to educate both the public and the providers. We do this through all of our programming, all of our individual programming, and very extensively through public health. The delivery of direct services to our clients. Most of you are very familiar with New Hampshire Hospital, Glencliff, SYSC, but then we also have all of our district offices around the state, which day in and day out take hundreds of calls from our clients all over the state to provide assistance with helping to navigate our systems. To protect, most of the things that fall into this category are things like DCYF, Adult Protective Services, and then other things that aren't as obvious, such as public health with disease surveillance and prevention. Regulatory more or less fall into that same category. It is a different avenue to protect the public. This is oversight over healthcare facilities, food safety, and child's care. So programs that you think of about, lead paint and the safety of the food that we eat, and then obviously COVID-19, all of those things fall under our public health domain and under the safety and oversight of the department. And then finally, ensure program and operational integrity. This is basically making sure that the programs and the funding are spent the way that we intended the funding to be spent. And this is something that is probably going to be built out over the next couple of years. We do a very good job of developing very complex contracts with our vendors and our providers and providing standards of care for many of our healthcare partners. And I think, where we're going to see some improvement and some changes happening is really along getting behind that contract and going in and seeing with our own eyes that the outcomes that we're paying for that we're seeking are being met, so that we make sure that there's positive outcomes from every dollar we spend within the department. Slide 5 is our organizational structure of the department. You will see here that there are 3 main areas of the department: population health, human services, behavioral health, and operations. And then we have our 24/7 facilities and our administrative functions there. I think this is also an area that you will see that's going to be up for some improvement in the coming years, maybe not this biennium, but in the future years. The department has long sought to try to integrate delivery systems, meaning if one family is in multiple systems, they have one care coordinator, they have one point of entry into DHHS. As we move towards integrating our delivery systems, this organizational chart is going to have to change so that it is also integrated and it's not siloed and fragmented. So that is something that is on the horizon. And I think as we start taking on some of the projects that you will hear presented by the department and by A&M when they do their presentation, we're going to see the organizational makeup of the department change also. Slide 6. This is our staffing, because I know this is always a hot topic during budget around increasing and decreasing staffing. So just a couple of notes on the staffing component of this. You will notice slight increases for 2021, 22, 23. The vast majority of the increases in staffing came from two main areas. One was the large increase in DCYF staffing that we implemented in the last 2 years, which I think we can all agree was definitely beneficial to the child and family services and the children that we serve in DCYF. We really shored up our child protection system, and at this point, we are logging probably some of the lowest case numbers in DCYF per child service worker, child protective service worker than we have in probably 5 years. The other increase comes from New Hampshire Hospital. As we move kids out of New Hampshire Hospital and into Hampstead, the plan is to renovate that unit and to increase the adult capacity at New Hampshire Hospital. So there's an increase in the budget to staff those units. And then additionally, we stood up PATH last summer, which is the psychiatric adult transitional housing. It's in the Philbrook building. So that was a quick stand up to really try to move some people out of the acute inpatient setting and back into the community. And the department is running that right now at 16 beds, and it's been fully occupied shortly after we opened it. I assume that many of you read the report from Alvarez and Marcel. I want to draw attention to the recommendations around staffing. Initially when A&M came in to do this project, their task was to try to find efficiencies within the department. We were looking down a year down the road thinking we were going to have significant revenue issues in our state. And we were trying to find a way to really create some efficiencies within the department. And very early on, A&M undertook a staffing analysis, and they looked at our approved FTEs. And just as a note, our approved FTEs also include unfunded FTEs. So it's all of the positions that are approved, but we don't use all of them. And they compared them to other states of similar size and similar scope. And what they found is that we were one of the lowest states in the country around our size for staffing. The way they described it to us is that our staffing is at a point where we are able to fulfill the transactional details each and every day, and that's your day-to-day tasks. When you look at transformational projects, when you're looking at moving the department in a different direction or making improvements to the system, we don't have the foundation of staffing to be able to do that because we only have room in our day to do day-to-day tasks. So what you will see is that they did not recommend any staffing cuts at all through their recommendations. They actually recommended increasing staffing to be able to complete the projects that they recommended in the report. So in short, we need every single position that is in our approved lines. We have high vacancy rates right now because we were in a hiring freeze for about 9 months of 2020. So we are staffing up and building our team back up to be able to execute on all of the projects and the timelines that we had intended to pre-COVID. I think everybody can agree that COVID kind of pressed pause on a lot of things, not just within the department, within the state. And it wasn't just state of New Hampshire employees or programs that pressed pause. We were still putting out RFPs for services, and our provider partners in the community didn't have the capacity to bid on our contracts because of the uncertainty in the environment around COVID. So it wasn't just the department saying, we're going to hold off on this. A lot of our providers just didn't have the capacity to help us with a lot of these projects. So we're staffing up. We've been staffing up for the last couple of months now, from everything from line staff to senior leadership. So I'm going to refer you to the part in the A&M report that talks about the staffing for a very good objective analysis of our staffing. And you will see there that we need each and every position that we have. With that, I am going to open it up to see if there's any questions before I turn it over to the rest of my team to finish up the presentation.
Thank you, Mr. Chairman. Hi, Commissioner. Are you able to provide us with numbers for the current biennium by division of how many positions in each division are filled
I'm sure
out of
that,
this 3153 authorized?
I'm sure that Karen Rounds can follow up with that information. It's probably not keyed up and ready today, but we
Right.
can do, we can provide that information, yes.
Thank you.
Senator Gaida?
Thank you, Mr. Chairman. Commissioner, can you provide us with the cost and the level of implementation so far of the Unite Us closed loop data system that the department has purchased?
I can provide you an update on just the department end. As you know, Unite Us and the closed loop was implemented on an IDN level, not by necessarily by the department. So I can update you based on what we've done.
That would be appreciated. Thank you.
Senator Rosenwald?
Thank you. Typically, the department provides this fabulous white briefing book by program that talks about caseloads and cost per case. Has that been provided yet? Did House Finance have it, and are we getting it soon?
I did provide it to Deb this morning. It is, I think, around 100 pages, so I'm not sure that she had time to print it this
No, I'm
morning.
sure she is. And thank you.
Yeah,
You're welcome.
members will find that in the OneDrive.
Oh,
It's 300 pages.
thank
Oh,
you.
300. I was
So
off
it's
200.
digital. It's digital this year.
Further
Thank you.
questions?
Yeah, just one.
Senator D'Alessandro?
Thank you, Mr. Chairman. Thank you, Commissioner, for being here, and thank you, Karen, for appearing here. The problem that we're all facing, I guess, in all of our districts, behavioral health, the number of people in the emergency rooms, the number of adults and children. I've been checking on that every day, and was told that we're making progress, that Katia was working on contracts to get ahead of this situation. Where do we stand at this point in time?
I know that we are within weeks of awarding. They're in active negotiation with the vendors on the contracts. So the awardees have been picked, and right now they're settling out the contract details. I know that, this is something that you follow very closely, and I agree. I've been following it closely since I went to New Hampshire Hospital 3 or 4 years ago.
Right.
And although some initial progress has been made and our numbers are still lower in adults than what they were 3 or 4 years ago, there is still a ton of opportunity to do things better. And I think what you're going to see is, it took 10 years of the system eroding to get to this place, and it's not an easy fix. And asking people to stand up brand new programs takes time. And I know that's not what we want to hear. We want short-term fixes. I've been asked to do everything from stand up a temporary hospital to, to asking for another wing at New Hampshire Hospital. I think, all of those things are on the table, but no matter which way you look at it, standing up additional inpatient capacity or standing up community-based teams takes time and takes funding. And we started working on those probably in earnest the last 2 years. And I think we have made progress, and we do have some time left before we resolve this crisis. This crisis is being resolved in 2 ways. Number one is community-based. Everything needs to be community-based. We need to prevent the crisis. We need to keep people out of the emergency rooms. And the second is going to be additional inpatient beds. That doesn't mean that we should build a new hospital, the state of New Hampshire, but I do think the IMD waiver is going to attract private providers into the state to build a hospital. Now, ideally, that would have started 2 years ago because it's probably going to take 12 to 18 months to build a hospital. But if we don't take these steps now, 18 months, we'll be having the same conversation.
Further question?
Further question?
Lori, the transitional housing that we funded in the last budget, we haven't seemed to accomplish what we set out to do. We redid the Philbrook Center, and we got 16 people in the Philbrook Center. But if we can't transition people out of New Hampshire Hospital, and get them back into a more comfortable environment, we're just going to have a packed New Hampshire hospital.
Yes, and we have transitional housing rates under review right now and working with our partners. I do expect in the next 30 days to have news around transitional housing rates and how we're going to procure additional beds. There are two issues and obstacles to community-based behavioral health. One is the reimbursement rates, which I do have some control over, and we will be making some suggestions for changes there. The other is workforce, something that's not an easy fix, but we do plan on using some of the COVID money that is coming to us from the federal government to do some very aggressive workforce development around behavioral health.
And one further
Follow-up?
question. And the 10 children that we now have ensconced at New Hampshire Hospital, which I don't like to see, but obviously we've got to find a place for them. Is there an effort being made to get those kids out so that the 40 beds that we had planned when we originally got the kids out, that situation could be completed and we would have more, we would have more capacity at the hospital? Is that?
Yes, I think we're about 30 days out. I'm going to say give or take on moving the kids back full-time to Hampstead. We have a much smaller wait list right now. I think there was 12 or 13 the last time I checked on for children on our wait list today. And as Hampstead brings on more capacity and we build out the children's system of care, we're about to award a PRTF, which is a psychiatric residential treatment facility that's going to decrease census at Hampstead. I do foresee in the next 30 days or so that we'll be able to transition those kids out of New Hampshire Hospital and then start the renovation to do increased adult beds.
Thank you. Thank you.
Thank
Thank you,
you.
Mr. Chairman.
Any further questions? Senator Rosenwald?
Thank you. I'm looking at page about the repeal of graduate medical education. We've been suspending that provision for a long time, and I'm wondering why you think repeal is better than just suspending it again. Is that never coming back?
I'm going to have to get more information from you on that question and get more details from my team because I don't have an answer to that right now.
Thank you. Further questions?
Further question?
Thank you. On page, not numbered, but Medicaid programs. You have the in and out program, which I know was passed last year, the policy. I understand that it requires just about $11 million of general funds, but the requirement is already law. How will the department fund it if we don't add the 22 million total funds?
Karen, can you speak to that?
So while I have a minute, Deb, can you please bring over John Williams? I forgot to ask for that this morning. I'm sorry about that, John and Deb. So John, we are going to go through those HB2 items, or John will, in a few minutes. If we do not have the funds to implement the program, we can't implement the program. Even if the law tells us we have no way to do it if we don't have the funds to pay for it.
Further question, please.
Further question?
What is required in terms of money for the expanded home visits?
I believe that is I believe it is a separate request. I can also hit on that when we get a little bit further in the slides. And I believe that Henry Lippman will also cover that in his presentation.
Okay, and one final one, if I could, Mr. Chairman.
Yeah.
On HB2 funding request, in the House $50 million back of the budget cut footnote, they had some carve outs. Do you know why they elected to allow cuts to behavioral health? and did not include that in the carve-outs?
Well, I actually had a conversation with the House representative today about the carve-outs, and I have a problem with any carve-outs, to be honest with you. If you're going to ask me to cut $50 million out of the budget, then I would need the entire budget to be able to pull that $50 million. Asking me to cut $50 million out of only 25 or 30% of my budget makes it next to impossible. So I don't know exactly why they didn't include behavioral health in the carve-outs, but I would advocate that there not be any carve-outs if you're going to give me a back of the budget cut.
Okay. Thank you.
Any further questions? Commissioner, could you tell me if mental health issues, substance abuse issues are still rising?
When you say issues, do you mean claims data, or I guess I need more specific what you mean, or I mean the need.
Are we
It depends on. Go
Are we
ahead.
spending more and more money on mental health and substance abuse issues than we were, say, 4 years ago?
I would say yes, but not necessarily general funds. We had a major SAMHSA grant that came in that funded a lot of pretty much all of the Doorway program. A lot of the funding around inpatient behavioral health is Medicaid, Medicare, those types of things. So not all general funds, but specifically the increase in those needs can be addressed by behavioral health or by Karen. What I can tell you that during 2020, the pandemic has shown us an unprecedented need for children's behavioral health, something that we hadn't seen before. Typically, there's ebbs and flows and the needs for kids for behavioral health, and the needs for children skyrocketed. So in that area, I would say that there's unprecedented need for children's behavioral health right now.
Okay. Since if we look at the fiscal year 2023 House passed budget versus the fiscal year 2019, we have increased Health and Human Services some $540 million. And I'm just always curious as to why these things are continuing to increase, because I think at some point in time, you might come to the realization that you're never going to spend your way out of trying to react to something that's happening. So I guess my question is, what are we doing on the front end? Because I like your statement about the success is preventing crisis. So what are we doing on the front end to prevent crisis?
That's it, right? That's it, Senator Daniels, is getting into the community. The behavioral health crisis, right, it starts and ends in the community. We need to prevent people from getting to the ER to begin with. That means we need to have mobile crisis teams, functional supports. We need to have critical time interventions. We need to go into people's homes and provide them treatment. Our treatment cannot be when they call 211 or they call 988 soon, is going to be to go to the emergency room. That is the default, and we need to stop doing that. That's not necessarily the department, but we need to put the programs in place that if you end up in the emergency room, that the ER doctor knows exactly who to call to get you out of the emergency room and into care in the community. That's what we're trying to do with CTI, mobile crisis, and all of these programs. When I was at New Hampshire Hospital, I talked a lot about the backdoor problem, a lot about needing supported housing for people to go and live, because without that, we have people leaving New Hampshire Hospital, they go home by themselves, or they go to a shelter and they decompensate in 60 days and they come back. So until we provide a supported housing environment and community-based care, we will continually see this revolving door of patients.
Okay, but I still look at your comments as being reactionary just at the community level. How assertive are we being to ensure that it never becomes a need to go to a mobile crisis unit or something in the community?
I agree that so what you're asking is about prevention programs in the schools?
Well, that could be one part of it.
Absolutely. I think some of that has to do with workforce development. Right now, if you decided that you needed to go to counseling and you wanted to call and get an appointment, you're probably looking at 6 or 8 weeks. Most people know that when you get to the point of reaching out for help, waiting 6 to 8 weeks is not going to suffice. Those are workforce development issues that we need to take care of in the state. There's a lot of things that we're going to be doing in the coming months with the CARES Act money or the relief money. And some of it is around behavioral health workforce development. That is the key obstacle to being for prevention and providing the care before it gets to crisis. Because I completely agree with you. We need to address it before it hits crisis.
Thank you. Any further questions from the committee? Seeing none, thank you. Go ahead and continue.
All right, I'm handing this over to my team now, and my team will take over from here. Thank you all. And we will get back to you with the information that you've asked that we didn't have answers for today.
Thank you, Commissioner.
Thank you.
Thank you, Commissioner. All right, so going back to the slide deck. So what I did this year different than last biennium is with the OCON presentation, rather than just going through the Office of the Commissioner budget, what we did is created an overview of the entire budget. So this is a preview for everything you're going to see within each of the divisions. We also added 2 slides, which we're going to start on here in just a second, to overview changes to HB1 footnotes and HB2 language. So the first box there is the HB1 footnotes. We have 3 accounting units, which we are requesting non-lapsing within the biennium language. The first 2 we did request within the House, and we did discuss them. I'm not sure why they didn't decide to bring them forward for a vote. The third one is state phase down. We do have a request for additional funds in that accounting unit. If additional funds are not appropriated into that accounting unit, at least having it non-lapsing would give us some flexibility to make sure that if we do have enough money in the second year and there's anything left over, that we can carry that forward to the second year for any shortfall, because there is always a rate increase in state phase down. What I would also mention is we're going to stick to the slide deck, but you should have also received today a backup document for this, which looks something like this. So that you're not going to go through word for word. We're going to stick with the slide deck, but you do have that as backup. So go ahead, John.
Ms. Rounds, thank you. And Senators, good afternoon. John Williams, the Director for Legislative Affairs for the Department of Health and Human Services. And we're making under HB 2 7 language requests of the Senate Finance Committee. The first of which is involving the direct and indirect graduate medical education payments. As Senator Rosenwald had pointed out, that has been in the budget since 2009 for HB2 and has been suspended for now going on 12 years. There is no funding specifically that has been ever provided since at least for 12 years. And as we go through every single budget cycle, we're required to having our Medicaid staff, to have our Medicaid staff file a state plan amendment and to seeking from CMS to continue the suspension of the medical education payments. So
John, we're having a problem hearing you, John.
Yes, my apologies. Let me
Turn it up.
Okay, hopefully you can hear me better now. So as to direct and indirect medical education payments, as stated that we go through every budget cycle having to seek a state plan amendment with the Centers for Medicare and Medicaid Services. And so to seeking suspension of those, considering that there's been no funding in over 12 years for this program, it makes sense from an efficiency standpoint to seek a repeal through a state plan amendment to CMS because of the fact that every budget cycle we have to go through this exercise. So it certainly helps the department in for a not to exhaust any resources unnecessarily for a state plan amendment. As to the next item, the eliminating the social services block grant rulemaking requirement already contained in both the governor's and the House budget is related to a cost of living adjustment based upon the Social Security Administration for the Social Services Block Grant. And under the Social Services Block Grant, they provide services for individuals who are 60 or older or ages 18 through 59 who either are chronically ill or have physical disabilities. These are individuals who are not Medicaid eligible, but receiving such services as Meals on Wheels, home visitation, and other services. And so because we go through the exercise already as part of the HB2 process of getting into the trailer bill to the budget, the cost of living adjustment based upon Social Security Administration, we're also required to duplicating that exact same effort as it relates to rulemaking. We have to go to the Joint Committee on Administrative Rules to duplicating those efforts every budget cycle to essentially do what you folks have already done as part of the budget. So respectfully, we're asking that requirement that we have to take the additional and necessary step to going before jail car, that we have provided language for your consideration, very similar to language we did that you folks were very good to enact in HB 4 from 2019 as it related to the budget adjustment factor in Medicaid. It was very helpful, and it certainly is productive and increases efficiencies for the department. The next item is extending the prospective repeal related to the waitlist of community mental health centers. And this comes from the LDA audit that was done in 2010 as it related to the behavioral health delivery system in our state. And the legislature enacted HB 191 that identified specifically the delivery of services under RSA 135C-18 that there was reflective of the audit relative to delivery of services. In 2013, in the budget, there was an extension of the prospective repeal to essentially accommodate for the community mental health centers for an efficient delivery of services based upon those resources. So this section has been in the budget since 2013. The community mental health centers and the department support this language and would request that it be added as a language request to HB2. And next slide.
So there's language in there for 3 different programs, and Senator Rosenwald touched on this earlier, that we also have requests to fund these programs. So we either need to fund these programs or suspend them or repeal them for the biennium. Similarly, that is the case with long-term supports and services presumptive eligibility. Medicaid does not allow for presumptive eligibility with nursing facilities. And so there is a general fund cost to this. This was suspended last biennium, and it was suspended last biennium, yes, and we're asking it to continue to be suspended. The last one here is reproductive health facilities. There's a request for HB2 language for about $400,000, which we will cover in more depth in the public health presentation. So any questions on HB2 language for John or I?
Senator Gaida?
Thank you, Mr. Chairman. Thank you, Ms. Rounds. Direct and indirect medical graduate program, that's been suspended for quite some time, as I understand it, payments to that. Is that the program that pays out to doctors to go to rural clinics? Is that program?
And Ms. Rounds, if I could address that question, or Senator Daniels, I'm prepared to address that question.
I can't hear it. I can't understand it.
Yeah, John, we're having a very hard time hearing.
Yeah, I apologize. For whatever reason, I've had a very obviously difficulty speaking at this moment, but I'll do my best to respond to that. The direct and indirect graduate medical education payments are made specifically directly to hospitals. And they're for teaching hospitals. The direct costs are for staff who actually administer the residency programs at the teaching hospitals for physicians and medical students. And the indirect part of that is related to the ancillary costs, such as additional testing that is required at the teaching hospitals and other related costs due to the fact that they are teaching hospitals, which are going to increase those costs. So Senator Gaida, the direct and indirect medical graduation, medical education payments are specifically made to hospitals. The program that you're referring to that the state has, which is separate from this, which has not been funded, as you are well aware, for 12 years, is managed under our State Office of Rural Health. And it relates to the state loan repayment program, otherwise known as SLRP. And those are actually paid directly to eligible clinicians, physicians, and others to offset the cost of their medical school student loans and or clinical student loans for other providers such as dentists. So those are the ones you're referring to that are directed to the underserved areas and underserved populations related to our state loan repayment program.
Follow up. Thank you, John. That was a really good explanation.
Thank you.
I have a question on juvenile diversion. $600,000 is in the last biennium. 300,000 was paid because when COVID hit, everything got slid a year, basically. There's not a line item in the budget for that juvenile diversion. I'm wondering what department within, or what part of HHS that would be funded in. Now, it's contained somewhere within a program, and I'd like to know where that is because I plan on trying to get that funded.
I believe that it was funded within DCYF. So I'll do some research on that and I'll be prepared to talk about it during the DCYF presentation.
Thank you.
You're welcome.
Further questions? Senator Hennessy?
Sorry, could you please remind me what the in and out program is?
And Senator Daniels, if I may respond. Senator Hennessy, good afternoon. The in and out program is otherwise known better as the bend down requirement. So if an individual is who is receiving a Medicaid, for example, currently right now, the one household member has an automatic $591, and it is increased obviously for a 2 household members. And if they have assets that are greater than that $591, as a condition of getting into the Medicaid program, they have to spend down that amount. So if an individual had, say, under the example of the one household member at $591, had $2,000 in monthly income, they would have to spend down the equivalent of the difference between the $2,000 and the $591. And at that time that they did that, they would then be in the Medicaid program and eligible for those services.
Thank you.
Any further questions? Seeing none, please continue.
All right, great. Thank you, John. All right, so moving along, the next few slides are all accounting changes and funding requests. And similar to the previous few slides, there is a backup document that I'm not going to go through. I'm sure you're all thankful for that. It's many lines and numbers. And that is available that I provided to Deb this morning. I'm also not going to go through each of these on the slide because each of these will be covered again in the division presentations. The first section is the sort of the typical accounting adjustments that you have seen in past bienniums where we're moving a position or we realize that the funding source wasn't correct or types of things like that. What these net to is a $2.6 million general fund reduction for the biennium. Two of the major things that you will see in there is that DISH for New Hampshire Hospital needed to be adjusted. There were some new federal regulations that came out in the past several weeks. And so we've done an adjustment for that, as well as a need for TANF MOE. We are required to spend general funds to be able to spend $1 of TANF. And so that will also be covered in a presentation this afternoon, but I have included that in the accounting adjustments because we must do it. Then the next section is the request made by the governor to be included in the House budget. There was a letter sent by the governor to the House suggesting things that should be added to the budget with the higher revenue estimates. And so I've included those and labeled those as 1G through 8G. I also broke out standard Medicaid and CHIP into its own section. And there are, I believe, a total of 4 or 5 adjustments there. I would note I made a keying error on CHIP. And so I've already sent over to Deb a version 2 of the summary document, which corrects that CHIP error. And Henry Littman will be covering those in more depth in his Medicaid presentation. On the departmental needs, those are labeled 1N through 9N. There are several different requests. The first 2 are related to the Office of the Commissioner, so I'm just going to cover those quickly. The first one is health facilities, which is part of our legal and regulatory area. We have a position that does construction and renovation plan reviews for health facilities and long-term care facilities. We have been unable to fill that position for over a year, and we have facilities that need those approved. So we've had to contract out those services. So there is a request to pay for that contract. The second request that's related to the Office of the Commissioner is for many maintenance projects across the department. We maintain the Department of Administrative Services does not maintain our 24-hour facilities, so New Hampshire Hospital, Glencliff, SYSC. So we do have to maintain those buildings as well as the 10 or 11 district offices that we manage. So there are projects requested to help support those things. Again, the rest of those bullet points will be covered within the division presentations. And the last section is I broke out SYSC separately to fund in the second year of the biennium, as the commissioner spoke about a little bit earlier.
Mr. Chairman, could I ask her to hold for a second? I want to go back up to a couple of things she said and ask her to address them, please.
Okay, Senator D'Alessandro has a question.
Yeah, thank
Sure.
you, Mr. Chairman. Karen, in the first block, you cite some things that obviously resonate with me, and one, rate increases for transitional housing and adding additional transitional housing beds in FY23. How long have we been talking about this? We were supposed to be doing this in fiscal years 20 and 21. Were we not?
So we did add, I think the commissioner spoke about that earlier, about opening the PATH Center and those transitional housing beds.
And the second point, home visiting services as required in SB 270 must be funded or must be suspended or repealed. We didn't appropriate enough money to do this?
No, there was no appropriation last biennium because I believe that SB 274 takes effect 7/1/21. So it didn't take effect in the biennium that the bill passed.
But further question, Mr. Chairman,
Follow up?
don't you have fairly significant transfer capability in your department?
I do.
And it seems to me, if you saw a need in a particular area, isn't there the ability to transfer those funds rather than to lapse them?
There is, but I would not be able to do that with a $50 million back of the budget cut.
15, I'm sorry, what?
So, just further point.
Follow up?
Then you attribute your inability to do these things based on the back of the budget cut.
Because I don't believe that I will have funds in other areas to transfer anywhere.
Thank you.
Senator Rosenwald?
Thank you. I'd like to pick up on the transitional housing question. And Karen, I'm really struggling to hear you. So we appropriated in the current budget $5 million for 40 beds. Some amount of hundreds of thousands, I think, were used to renovate the Philbrook. Well, the rest, how much has left, and is that going to lapse at the end of the biennium, or is it non-lapsing?
I don't recall off the top of my head. I'm going to defer that question until we do the behavioral health presentation, because those funds, the remaining funds are in the behavioral health budget. So we should be able to answer that question during that presentation.
Okay, further question.
Follow up?
Thank you. Back on slide 8, you guys have a point about family planning funding, but you didn't address it. We're talking about like 12,000, at least low-income women's access to maybe what's their only health care. Could you expand upon what you're looking for and what the impact is? Are we likely to see other providers? Do we have a history of getting other providers in last time we defunded this program 10 years ago?
So I'm going to defer that question until the public health presentation on Monday.
Okay, fair enough.
I'm not an expert in that area to be able to answer
Thank
that
you.
question.
Any further questions? Seeing none, please continue.
Okay, great. So moving along to the HB2 funding requests, I don't think I need to address the first two. The commissioner addressed both of those in her presentation. So the last one is funding projects identified by Alvarez and Marcel, which the commissioner also identified this in her presentation. And so rather than spending any more time sort of introducing, I'm going to move right along to the last slide, which is slide 12. And we do have Alvarez and Marcel available here on the call with us. We do refer to them as A&M for short. I will just mention this first one here. I'm going to zoom in slightly. The first one here is maximizing federal 4E funding in foster care. This is something we've been talking about for years, and A&M was able to help us identify where our issues were and helped us start the process for being able to resolve that. So that is a project that is in process and that we will be continuing to work on throughout the biennium. The other thing I would mention about all of these is that there are anticipated savings with these projects, and the House did put the anticipated savings into the lapse estimate for the budget. So that's where those savings were identified. I would also just mention that we will cover the DD redesign as we start the long-term supports and services presentation. So with that, I'm going to turn it over to Brendan Stalley.
Thank you, Karen.
Yeah, please continue.
Okay. Good afternoon, Mr. Chairman, members of the Finance Committee. My first question for everyone is, can you hear me okay over the audio?
Loud and clear.
Okay, great. Thank you. My name is Brendan Stallard. As Karen mentioned, I am a senior director with A&M and the project manager for the A&M team who has put together these recommendations for DHHS, some of which we are going to talk about in more detail today. Just to provide some context, we have a few other members of our team here that are going to go through each individual recommendation. As Karen mentioned, we're going to focus for the next few minutes on those related to behavioral health, specifically critical time intervention, the CMHC funding, and the SMI IMD waiver. And so with that, I'm going to introduce Tyler Stone and Matt Smith, who are going to walk us through an overview of the Critical Time Intervention Initiative. So Tyler.
Thank you, Brendan. I'll ask the same question Brendan asked just to make sure. Can everybody hear me all right?
We can, not as clearly as Brendan.
Well, that's usually the case with the two of us. I apologize. How about now? Is that any better?
Yeah, I think that's good.
You could go down with your volume slightly, Tyler.
Okay.
And it'll be clear. Yep, that's better.
Fantastic. Thank you, Brendan. Thank you, Mr. Chairman, and members of the committee for the chance to speak with you. As Brendan said, my name is Tyler Stone. I'm with Alvarez and Marcel, and I'll address the critical time intervention component of the table that you just saw, as well as the CMHC funding component. And I'll start, of course, with critical time intervention, or CTI for short. CTI is a community-based practice that mobilizes support for adults with serious mental illness during vulnerable periods of transition, particularly during discharge from a psychiatric hospital. The model provides transitioning individuals with the support they need to successfully reintegrate into their home communities. This can entail a broad range of assistance, from helping an individual secure employment, housing, or food, to identifying and accessing mental or physical health care, to reconnecting with family, friends, or peers to ensure strong supportive relationships. There are three primary benefits to implementing CTI statewide in New Hampshire. The first is its positive impact on the health outcomes of New Hampshire citizens. CTI increases the likelihood that people transitioning out of psychiatric hospitals will reintegrate successfully into their communities, thereby avoiding a relapse that may put them back into the hospital. Extensive academic research supports this. Randomized controlled trials have found that CTI can reduce hospital readmissions by as much as 26%. And as mentioned before, CTI helps people leaving hospitals identify and secure the critical things they need to live independently: a job, housing, food, relationships, and so on. Every person that CTI can help reintegrate into their community and thus not be readmitted to a hospital is someone once again able to be a contributing member of society. The second benefit is cost savings to the state. The average cost of an admission to New Hampshire Hospital, for example, for someone under 65 is approximately $1,500 per person per day. Many individuals can stay at the hospital for weeks or even months, and as you can imagine, the cost can therefore quickly add up. CTI, in contrast, is far less expensive, averaging as low as $4,000 per person per year. Thus, while there is a recurring cost to pay for the provision of CTI services, that is to say, the agencies around the state that would potentially deliver the service, there is also recurring annual cost avoidance. We anticipate that for every million spent by the state on CTI, it could save 1.3 million in avoidable inpatient hospital cost. Third and final, CTI will help reduce the number of individuals on hospital wait lists by creating a more efficient model of care at hospitals. The need, as we've discussed multiple times today, for such waitlist reductions is even greater now as a result of COVID-19 than it was before the pandemic. Fewer individuals readmitted and instead reintegrated into their community means less pressure on the hospital system, allowing hospitals to admit and process individuals faster and more effectively. In sum, CTI presents a very unique opportunity to both improve the health outcomes of New Hampshire citizens and at the same time pave the way for a more cost-effective and efficient model of care at hospitals. That's all I'd say for the moment on CTI, though of course I'm happy to take questions on the subject before addressing the other component around CMHC funding.
Any questions regarding CTI? Senator Rosenwald.
Thank you, Mr. Chairman. Could you tell me which recommendation in your report it correlates to? I'm looking at
Certainly.
the report and I don't see those initials.
Certainly, Senator. So if I'm not mistaken, in the Phase 1B report, that portion of the report, there is a section entitled Behavioral Health.
Yes.
And critical time intervention, or CTI, is a component of that section.
And what page is that?
I apologize, Senator. I don't have the page number in front of me at the moment, but we can investigate and get that to you or to Karen to share with you.
I can check on that, Senator, as we continue here for you.
Thank you.
Okay. I just don't see anything that looks like 6.9 million that delivers significant savings. Thank you.
Senator, I couldn't comment on 6.9 million. I believe for CTI, we've in the budget, we've identified $1 million in funding per year, and the projected savings are roughly, if I recall, about 1.7 million.
I apologize. I probably should have spent a little bit more time on the chart. So the 6.9 that I referred to on the previous slide is a total of the 6.4 and about 0.56, $500,000 related to DD redesign. CTI, the CMHC funding, and the IMD waiver, as well as the 4E changes, are all funded in HB2 currently. What we're requesting is to also make sure that the DD redesign is funded.
Further questions? Okay, thank you.
Thank you, Senators. I'll comment next briefly on the next item in that table called CMHC funding. This particular line item, it actually more specifically refers to adjusting how the CMHCs, the community mental health centers in New Hampshire, are funded for a very particular service that they deliver. The primary benefit of doing this is cost savings to the state. As you all know, the CMHCs provide a critical role in the state. They're a critical part of the state's continuum of care. They offer a range of mental health services to the citizens of the state. One such service is Assertive Community Treatment, or ACT, which provides treatments for individuals with serious mental illness in their community rather than in a hospital setting. This service is funded today via a combination of Medicaid reimbursement and state general fund dollars. Our report proposes modifying how ACT is funded by creating what's called a bundled rate that could save the state up to $1.7 million per year. Today, ACT providers must bill for each individual component of the ACT model, and many of those components are not reimbursable through Medicaid. The state provides direct annual payments to the CMHCs as a result to offset much of this cost. Creating a bundled rate for ACT would enable ACT providers to be reimbursed for all ACT services they deliver at a single regular rate, possibly on a monthly basis. A bundled rate would thus allow for ACT providers to be reimbursed through Medicaid for all aspects of the ACT services that they deliver in a more predictable and sustainable way. The anticipated savings that I mentioned would result from the state discontinuing its annual direct payments for ACT, as they would no longer be needed with a bundled rate in place, and from the increase in Medicaid reimbursement for ACT services. The department has the resources to develop this rate and to submit the appropriate documentation to the Centers for Medicaid and Medicare Services for approval. The only and one-time cost in the table is $200,000, and that's the anticipated cost of a third-party accounting firm to review the rate before it is actually submitted to CMS, which is a very standard practice when setting rates of this kind. And that's the extent of my comments for that particular line item. Again, happy to field any questions if there are any from the committee.
Any questions regarding CMHC? Senator Rosenwald.
Thank you, Mr. Chairman. Will you be able to show us where in your report that leads to identified savings?
Senator, we're more than happy to. I can look into that right now, and I can probably message that to Karen or others on the department's team, and they can share that once we've identified the exact page number for you.
Thank you.
You're welcome.
Seeing no further questions, please continue.
That does it for me, Senators. Thank you very much. I appreciate it. I'll turn it back to Brendan, I believe, who will carry things forward from here.
Thank you. Have a good day.
Thank you, sir.
Great, thank you, Tyler. Before we move to the IMD waiver recommendation with Jay Nagy, Karen, I think we're looking about page 7, where we're covering the CTI details in the report. It may depend on the version or the printout the senator is referring to. That all said, as Tyler mentioned, we're certainly happy to clarify through follow-up to this presentation on that question or any others that do arise. Okay. Thank you. So Jay Nagy, we're going to hand it over to you to discuss the IMD waiver.
Thank you. And thank you, Mr. Chairman and members of the committee for this opportunity to speak with you this afternoon. For the record, my name is Jay Nagy, a senior director with Alvarez and Marsal. This winter and spring, we've been reading reports in the press and hearing testimony in these budget sessions that the emergency department waiting list is experiencing a resurgence after having been virtually eliminated in March 2020. At its core, this problem can be broken down into inputs and outputs. Programs like the Philbrook Adult Transitional Housing Center are part of the solution by promoting timely discharge from inpatient care. Additional inpatient or IMD capacity is also part of the solution by promoting timely admission to inpatient care. And last but not least, robust crisis stabilization in the community is the third leg of the stool. The essence is to increase throughput across the system and get people in crisis the care they need when and where they need it. What I'd like to talk more about today is a catalyst to increase throughput, which is to say expanding the state's IMD waiver from the current focus on substance use disorder to include serious mental illness, SMI, and severe emotional disturbance as well. Why is a waiver even required? Since the beginning of the Medicaid program, the federal government has restricted Medicaid reimbursement for inpatient behavioral health care or care in institutions for mental disease, IMDs. Over time, the Centers for Medicare and Medicaid Services and its predecessor have loosened this restriction in the face of growing needs, most notably and recently by granting waivers of what is sometimes called the IMD exclusion rule. 32 states have received waivers for substance use disorder, including New Hampshire, and 3 states' applications are currently pending. Most importantly for our discussion today, 7 states have received waivers for serious mental illness and severe emotional disturbance, with 3 states' applications currently pending. You may be wondering how New Hampshire has gotten by without such a waiver so far. As the state's largest and most notable IMD, New Hampshire Hospital benefits in a large measure from the Disproportionate Share Hospital Program, or DSH, which offsets the cost of care that would otherwise go uncompensated, given the exclusion rule. The only IMD that benefits from this arrangement is New Hampshire Hospital, something that has limited the interest and ability from the private sector to partner with New Hampshire to work on reducing the emergency department waiting list and achieving other important transformational goals in the state's behavioral health system. With an expanded IMD waiver, the idea is that one or more private sector partners would develop privately funded and privately operated IMDs to expand inpatient beds and, importantly, offer much needed community-based services as well, such as mobile crisis teams and transitional housing like the Philbrook Center. It's worth reinforcing that this is an all of the above type strategy that is not limited to increasing inpatient bed capacity. It is comprehensive in nature, addressing both the inputs and the outputs, to come back to my former analogy. Basically, with Medicaid being such an important payer for behavioral health services, no private sector organization would want to risk the losses incurred if Medicaid cannot reimburse stays for people aged 21 to 64, as is the case under the exclusion rule. And one final crucial point to make: what is the cost of doing nothing? Reducing the waiting list is not just benevolent policy, as important as it is to connect people in crisis with the care they need in a timely manner. There are actual costs to the state, to hospital emergency departments, and to other payers, to maintain people while they're on the waiting list. From the House Division 3 hearing on March 1st, we saw that there were 1,424 boarding days recorded in the month of January this year. On a run rate, that equates to over 17,000 boarding days per year. According to a 2013 report published by the Foundation for Healthy Communities, which we cite on page 19 of our report for Phase 1A, 36% of people on the waiting list are covered by Medicaid, 23% were self-pay or uninsured, and 41% had other insurance, including Medicare and commercial. If anything, following Medicaid expansion in 2014, the share of people on the waiting list covered by Medicaid is likely even higher today. There is not a lot of data in the public domain to help quantify costs, but one per diem estimate of the cost of boarding someone in emergency departments is $2,264 per day. That comes from an emergency medicine academic journal that we reference on page 13 of the Phase 1A report. The state is a significant funder of these costs, both through Medicaid reimbursement and uncompensated care, or DISH. Some portion of the cost is absorbed by the hospitals, and we are working with the New Hampshire Hospital Association to better quantify this amount. We can't yet tell the exact impact that will have on the estimates that we published in the report. And we walk through these calculations in detail again, beginning on page 19 of the Phase 1A report. Even though we continue to engage stakeholders to help refine these estimates, we believe that directionally they are both illustrative and instructive. Any modification is unlikely to change the overall conclusion and recommendation. But in one sense, the key takeaway is that it's actually more complicated than any of those calculations anyway. There's the direct cost of boarding, which we just highlighted, but just as important are the risks to health and safety for other patients and emergency department staff that result from boarding. Last but not least, and also hardest to quantify, is the exacerbation of symptoms while people are boarding, which can lead to longer lengths of stay in the IMD, more intensive courses of treatment, and certainly greater harm. The request in HB2 as amended is focused on staffing resources to support the implementation of this initiative, specifically a waiver administrator to oversee implementation, as the expansion of the current SUD waiver is complex and requires dedicated oversight. Revenue cycle personnel for New Hampshire Hospital to support the ability to bill Medicaid for more of the care and services rendered. And lastly, additional hours in the contract for the state's actuary of record to support ongoing reporting, monitoring, and evaluation requirements. And I'd be pleased to answer any questions from the committee.
Are there any questions from the committee? Seeing none, thank you very much.
Thank you, Mr. Chair.
Great. So with that, we're pretty much ready to transition over to the developmental disabilities and long-term supports and services presentation. So I think Deb needs to bring a few people in, and John is all set. So I don't know if Deb, you want to take a minute to do that. Also, Tyler and Jay don't have to stay. They are all set as well.
Yeah. Why don't we take about a 10-minute break? And then we will come back and start the next section.
That sounds great. Thank you, Chair.
Thank you.
We paid those guys $1.2 billion. We paid them 1.2, and they ended up taking 1.5.
Hey, Deb, I'm not sure if you're there, but we do need Deb Sheets as well.
Could you please not share for a moment? We want to pull somebody else in. Thank you. Okay, you can put the share back up. Okay, if committee will come back to order, we will take up the developmental disabilities summary. I'll turn it over to whoever's presenting.
Great. I'm going to go ahead and turn it right over to Drew Smith and Deb Sheets.
Okay, thank you, Mr.
Great,
Smith.
thanks, Karen. I'd like to start by thanking the chair and the other members of the committee for the opportunity to discuss our review of the developmental disabilities delivery system operated by the Bureau of Developmental Services. As Karen mentioned, and for the record, my name is Drew Smith, and I'm a director with Alvarez & Marsal. To assist the committee in the discussion today, the DD review is covered on pages 24 through 53 in the Phase 1A report. In our discussion today about the funding request for developmental disabilities redesign, I would like to frame this discussion around two buckets. Bucket one comprises of a waiver redesign, rate development, and a modernization of IT infrastructure, while bucket two includes our recommendation related to intensive treatment services. In relation to the first bucket of items, our team conducted an in-depth review of the DD service system in New Hampshire. We concluded that under current processes, there are inadequate controls in place to manage waiver spend and to control costs. This lack of operational control has led to an inequitable system of haves and have-nots in New Hampshire. These inequities are driven by three primary factors: an unfettered waiver structure, antiquated rates, and inadequate access to data. Specifically, under current waiver operations, all participants have access to all services once they enter the system, with few controls to help guide individuals to the most appropriate service, as indicated in Exhibit A on the slide showing the spread of waiver funding based on assessed need. As shown in this chart, there is significant spread across the system. In some instances, people with lower needs are receiving as much, if not more, than those with complex needs. In concert with these findings, under the current reimbursement rates, which have not gone through a substantive redevelopment process since calendar year 2007, there is little historical understanding of the cost basis or assumptions used in the current rates, leading to further misalignment between service cost and service reimbursement. As illustrated in Exhibit B on this slide, we see that within the same service, people are getting access to different funding and service amounts. And lastly, exacerbating our findings under the waiver and rate programs, BDS operates using outdated, siloed data systems, preventing its ability to more robustly manage the system and authorize and monitor services. As outlined in our report.
What's SIS?
Sorry. SIS, yes. So SIS is what's called the Supports Intensity Scale. It's a nationally normed assessment tool that is used primarily in the developmental disabilities service system for measuring the level of support needs someone has in a standardized fashion.
Okay, thank you.
Chairman?
You're welcome.
Well, Senator Gaida has a question.
Thank you, Mr. Chairman. Can you explain to me in layman's terms what that diagram A means?
Sure, yes. And we go into great detail in our report around this. We also use other common assessment data that's available within BDS. But in this first bar, what we're looking at is two functions. So along the horizontal axes where we see the total SIS score, this again is a standardized assessment of the level of need someone has. So a lower score means lower needs that someone would have in their activities of daily living, going to individuals with complex needs, typically complex medical and behavioral support needs. As we go up the y-axis, that looks at the total amount of paid funding for accessing services. So what this is showing us is that across the system, there is a significant level of spread for, regardless of how much support someone has as measured through those assessment processes on how much money they're actually getting. As indicated in our report, we found that there was really a marginal correlation currently in the system between level of need and level of fund.
Thank you.
You're welcome.
Please continue.
Any other questions, or may I proceed? Okay.
You may proceed.
Great. As outlined in our report, we strongly recommend that interventions be undertaken to correct these challenges core to service management. Such investments will realign service spend with individual need much more appropriately. Specifically, as documented in our report, we strongly recommend that the waiver structure be redesigned to best align access to the most appropriate services at the front end of service entry. This is achieved by moving the singular waiver structure into a dual waiver based on assessed need and living situation. Second, the rate reimbursement methodology should be updated to ensure the cost of providing services is both covered, but also aligned with level of support someone needs to ensure tighter fiscal alignment in the system. And third, a more robust data system should be in place to manage and monitor the system more appropriately. The goal of these recommendations is to move away from the system of haves and have-nots to one where each participant gets what they need, no more and no less. These are key to long-term system sustainability and are an important step to promoting outcomes for those with developmental disabilities in New Hampshire. The total investment to the state, as outlined in the report for these three recommendations, between $800,000 to $1.2 million. However, by not making these investments, the issues outlined earlier will continue to compound and drive the likelihood of overserving some, or more importantly, underserving others, raising risks to health and safety. Before I move on, we do have a few other images on the slide. Again, these are showing the recommendation of splitting the current waiver structure into a dual waiver, and then an example of what a rate redesign process would look like to build the rates for new services under the waiver program. But happy to answer questions about either of these before moving on.
Senator Gaida.
Thank you, Mr. Chairman. So as I'm reading these, and if I'm wrong, please be quick to point this out. We're not hitting the mark on matching funds to need. Is that a safe statement to make?
Correct.
All right,
That
so
is a safe statement to make. Not in a current purposeful way. Right, I do want to say that there is some of that likely happens through case management, but in our review of the system as a whole, overall, that is not currently happening.
follow up.
Follow up?
How much of that missing the mark is attributable to training or data processing or any other factors? Again, we haven't had the benefit of reading this report. So what I'm trying to do is find causation, and then we can maybe more specifically direct funding to address needs.
Sure. So unfortunately, like most things in human services that have such a hands-on approach to assisting people in their lives, it's not an easy one answer to that question, I think. The biggest challenge in this fiscal component of matching need to dollars, I think, is primarily a function of the case management practices and the individualized budget approach, coupled with the fact that the state has not used a standardized assessment to directly align individualized need with dollars in the past. So as we looked at the spread on the previous slide, that is New Hampshire data. That is similar data that I would expect in another state that is not using structures or controls in the waiver management and rate management process to also be visible and apparent. So I do think that it is primarily ensuring that there are adequate controls in the system to help support that. And then there is also going to be a need to ensure that the services in the waiver align with those different functions of what someone actually needs access to help ensure the right alignment between dollars and need as well. But there are a lot of factors. The other piece of this, and we talked about it in a fair amount of depth in our report, BDS is operating, to be frank, with very poor access to IT infrastructure. The complexity of this program, the complexity of needs for the individuals served by this program, up against the siloed systems that they have to operate this does not, it almost drives you to make the assumption that there would be lower need or lower correlation in this process anyways, because the systems aren't there to support what BDS is trying to operate.
Seeing no further questions, please continue.
Oh, Mr. Chairman, I did have my hand up.
Oh, I'm sorry.
That's okay. I finally found the raise hand feature. Sir, in your report, you recommend that we reduce wait list funding for people who are on the wait list and save $4 million. I'm wondering if the lack of spending relative to an approved plan is because of workforce shortages, and whether if we had the workforce, the allocation would actually line up better with the spend.
So I'll answer part of that, and then I'll also provide Deb Sheets the opportunity for some of the funding pieces there as well. So our review of waitlist funding was primarily a review in current process changes that were already underway at BDS. In our review of the changes they were making, we agreed with that process change. We also then made some recommendations on how to better support that and better manage that through some modifications in how they were collecting cost data and projecting cost data. As to the workforce, I do think you're exactly right. And I think this is going to be exacerbated through this pandemic, and something that we should be very cognizant of right now. And we're actually doing work with BDS right now to better understand the fuller impact on the workforce within the private provider network. It will be a significant impact on how services are delivered and provided moving forward. The stress on families during this pandemic will likely push additional people who aren't currently actively engaged in service delivery to consider service delivery. And we then bump that up against having too few hands on deck to actually support those people in a quality fashion. So I do think there's a correlation there, a relation there to how people have access to services in the past. Just because you want them, if no one's there to deliver them, then there's a problem. And there does need to be focus put on the workforce. But Deb, I'll let you speak more directly to the waitlist funding as well.
Right. Thank you, for the question, Senator Rosenwald. Over the past 2 years with the COVID, this past biennium, Workforce has definitely contributed to our ability to start people and to fulfill their complete service requirements, and workforce is definitely a matter. In addition to that, because of COVID, we, as you know, the area agencies do put out requests for proposals. And there was some difficulty with the providers responding to those proposals because of COVID. In addition, we have families who chose not to start engaging in services during the height of COVID, and they determined either to delay or to not start services. Our area agency partners have done an incredible job over the past 4 months working on standing up vaccination clinics with our regional public health networks, which has stretched their capacity themselves to be able to work together with families on service coordination plans, but they are actively pursuing this at this point in time. And as you know, we had the closure of Crotchet Mountain that resulted in us having to do placements for those individuals, as well as start the people who are coming off of the wait list, who are A's, who are exiting the school system, or B's, who are new to the service system itself. So we've had many triggers that have impacted this particular biennium and have called further attention to the past, I would say, 6 years where we have encountered true workforce issues in terms of direct support professionals and supporting people in the home and the community.
Could I just follow up, Mr. Chairman, quickly? Is the department requesting to reduce funding to waitlist participants?
No, Senator, the department is not requesting that. What we have with this biennium budget that we're looking at is we have calculated the spend in the dedicated accounts. And what we have done is taking, essentially adjusted our appropriation so that we're taking the dedicated accounts and adding the appropriation to ensure that we have enough funding to support people to come off the wait list. And in SFY 22, we're looking at 226 people that will be taking off of the DD wait list. And in SFY 23, we're looking at 198 people that we will be taking off of the DD wait list.
Thank you.
Seeing no further questions, please continue.
Great, thank you. And I do want to take a moment to talk about the recommendation 5 in our report, the intensive treatment services. So at the time of writing our report, 38 individuals were being served in out-of-state long-term residential services at an average cost of roughly $384,000 per person, peaking at just under $500,000 per person in some cases. More directly, this group accounts for less than 1% of waiver population, but 5% of total waiver spend. Beyond cost, importantly, is the impact to people being moved out of their local New Hampshire communities and away from family and natural supports. Driving this need for out-of-state placements is inadequacy in current reimbursement rates, as well as lacking community infrastructure to support the complexity of needs for these individuals. Our report calls for a partnership between the state and private providers to build out the physical infrastructure needs for these individuals and a rate schedule that can more appropriately support the service in New Hampshire. While we do project potential long-term cost savings in this approach, it will require investment by the state to incentivize this shift. Depending on the level of state investment, we project the state could break even within 5 years. More importantly, however, is bringing people back home, reuniting these families, and supporting the full continuum of care locally in New Hampshire. In closing, I do want to say that New Hampshire has taken significant steps over the years in supporting people with developmental disabilities in the community. This commitment, made by the state, area agencies, service providers, and individuals and families, has sought to increase access to the community and promote meaningful lives for those supported. However, failing IT infrastructure and system management capacity issues has not done this equitably across the state. The investments called for in our report seek to bolster community access and quality through more equitable, sustainable, and manageable practices across the state. Our initial work with stakeholders to review these findings and recommendations have found general support in the system for these changes. I hope that the committee will consider our recommendations in context to the impact they can have on the lives of those accessing developmental disability services in New Hampshire, both today and those to come. I hope this information helps in your review. I thank you for your time, and I'm happy to answer questions from the committee.
Thank you. Senator Rosenwald, you're recognized.
Yes, thank you, Mr. Chairman. As I look at your report, if you're projecting costs of between, looks like $4 to $6 million for a savings of between 700,000 and 2 million for the intensive treatment service. Is that correct?
That's correct. So just to be clear, the initial investment is a one-time cost. What we've structured in the report is a grants program to help providers, private providers, build that capacity so that there is infrastructure for people to come back into the state. And so that's a one-time cost. Those cost savings we are projecting on an annualized basis.
Thank you.
Further questions from the committee? Seeing none, thank you very much.
Thank you.
So we're going to go ahead over to Deb and the rest of her division.
Good afternoon, and just as a second introduction, I'm Deb Sheets. I'm the Director of Long-Term Supports and Services, and I just want to recap what we are asking for. With Alvarez and Marcel, what we are looking to do is to restore the funding to support the developmental services system design transformation and develop in-state intensive treatment services. So this would require restoring the HB2 funding request to $10,260,000, which would include the $6,960,000 for developmental services that Karen referenced earlier in the presentation. The approach that we are taking here will have extreme active stakeholder engagement from the developmental services community that will include the area agencies, the provider community, and most importantly, the families that we partner with. It is a long-standing history in this system to do nothing about us without us. And our intent is to make sure as we take a look at tiering waivers and taking a look at reimbursement rates and the development of the in-state intensive treatment services to lean into our community and to do this in a way that is very specific to New Hampshire. And we are hoping that this funding can be restored so we can make major gains in terms of a continuum of care for individuals that might be dual diagnosis or are on the autism spectrum. And this is a terrific opportunity for us as a state to return these individuals home. So to get into the Division of Long-Term Supports and Services, the Division of Long-Term Supports and Services was established in 2017. It is composed of the Bureau of Developmental Services, which has 4 major program areas, the Bureau for Family-Centered Services, which has 3 major program areas, and the Bureau of Elderly and Adult Services, which has 9 major program areas.
Yeah, before you get into that, Senator Hennessy had a question.
Thank you, Chairman, and thank you, Deb. Nice to see you. Could you just expand on the HB2 appropriation? This was something the governor had in that the House took out.
That is correct.
Can you send us that language? Because I don't have that anymore since it's taken out.
We will follow up.
Thank you.
I will update the document that had all the HB2 language and send a new version so it all stays together.
Mm-hmm. Okay. Thank you. Some of the key challenges that we are experiencing, and I know that Senator Rosenwald probably hit at the most important one, which is we have a workforce challenge. We have a workforce challenge. We need to increase workforce capacity for home and community-based services, as well as for nursing facilities. The COVID crisis has really called attention to this, and it is across the board. It is within all 3 bureaus. Within my Bureau of Family-Centered Services, we are seeing nurses hit retirement age, and they are looking to not do the heavy lifting any longer, or maybe scale back a little bit. In the Bureau of Developmental Services, we are running into issues with attracting and maintaining direct support professionals, as well as those that have particular expertise with intensive treatment services, autism, and other areas of growth. And within the Bureau of Elderly and Adult Services, we continue to struggle with personal care services, homemaker services, And again, the COVID crisis called attention to that. The long-term care stabilization program was a shot in the arm that was able to carry us through, but workforce still remains an issue in home and community-based services. In addition, the bureaus have challenges with oversight. And we really do need the staffing. And I know that this was mentioned earlier on relative to the department overall, but the Division of Long-Term Supports and Services is not immune to the fact that we've had retirees and we are beginning to hire and onboard and bring people in. And to conduct transactional work and operational work is a challenge, but as we look at potential transformation, it is even more important that we be staffed and we be staffed with the right people with the right skills. As Drew had mentioned, information technology continues to be a major issue for us within our bureau. Within BEAS, we have a 23-year-old system that we are working with and we continue to work with and we struggle with, quite frankly. We do an awful lot manually. And in order to meet our, our challenges for compliance and oversight with our funding partners, it is a challenge. Within the Bureau of Developmental Services, we have systems that date from 1998 through 2015. None of these systems interoperate with each other, and I have to work manually to do my waitlist projections, and I have to work manually to take a look at matching data from my HRST, which is an assessment tool, and the SIS assessment tool, the support intensity scale tool that Drew had mentioned earlier on. To be able to transform our system, to improve our system, and to be able to work in a very, very transparent manner with our area agencies and providers, we need a shot in the arm when it comes to information technology. Our Bureau of Family-Centered Services does a decent amount through our Bureau of Developmental Services. So any investment made in this area will definitely have fruit for the Bureau of Family-Centered Services. Lastly, we are unique in that we receive several funding streams. The bulk or lion's share comes from our federal partners at the Center for Medicaid Services, but we also receive funding through Title V, which is another federal partner with different rules and regulations, through the Federal Office of Special Education. This is where we receive our Part C early intervention funds. And then through the Administration on Community Living, we get additional funding with different compliance and different opportunities to report out. And through the Administration for Children and Families, we get additional funding for our children with health and special care needs. So again, the ability to ensure that we protect that funding, that match, those opportunities is critical. And the information technology is a major, major player in making sure that we get there. Are there any questions?
Senator Hennessy.
Thank you. Thank you again for taking my questions. Is your IT request, is that on your capital budget and was it funded by the House?
The IT request was in the capital budget, and the three systems that I would call your attention to are the electronic visit verification system, the BDS direct billing system, the developmental services IT remediation system, and the BEAS modernization system.
And all of those were fully funded?
Karen, I am going to have to lean into you. I believe that the BEAS modernization may not have been fully funded.
I believe that's correct. I think everything except for that one.
Right.
And I don't think the governor introduced that one either. It wasn't that it was there and then was removed. I don't think it was introduced.
Thank you.
Senator Rosenwald.
Thank you, Mr. Chairman. Deb, is BEAS going to lapse any money this year from the CFI appropriation?
I would have to get back to you on that and take a look at it. I haven't taken a look at it in about 4 to 6 weeks. So I would make a commitment to come back to you and provide you with that information, Senator.
Okay. I mean, my question is really based on whether we would have an easier time recruiting a workforce if our rates were better.
As I said, I can get back to you and let you know what the potential lapse is if there is any.
Thank you.
Thanks.
So
So moving.
I got one more question, Senator Morse.
This question might have been for Karen earlier, but there's 3,150 some employees authorized in this last budget. What's the vacancy?
Current vacancy rate is about 15% department-wide.
She
That's
said
15.
15. I thought
Yes,
you had
that's fine.
700. Karen, do you have 700 vacancies right now?
So the 15% that I'm giving you is based on the permanent positions, which is what we presented on the slide. When you include our temporary positions, which include a lot of 100% federally funded positions, it is around 700. But when you look at just our full-time permanent positions, it's lower than that. It's like 400 and something, which equates to about 15%.
Thank you.
Thank you, Senator Gaida.
Yeah, this is sort of a stretch. Thank you, Mr. Chairman. Is there any way that in interviewing people, you can find out whether housing availability is a part of the shortage of workforce? I mean, we know it, but I'm wondering if that translates into the shortage that the HHS is seeing, and whether, a substantial increase even would in fact remediate that factor and enable us to have enough people to work in these jobs.
So that would be a great question for Chris Santinello, for a number of reasons, not just staffing for the department or staffing for our agencies, but we also have some work programs that we have with the TANF program. So I think Chris would be a great person to answer that question. And she has the housing program as well.
Thank you.
You're welcome.
Thank you. Seeing no further questions, please continue.
Okay, so what I wanted to do is begin by just sharing a little bit about our Bureau of Elderly and Adult Services. The Bureau of Elderly and Adult Services provides services for our older adults ages 60, and then older adults, and then adults with disabilities or with medical issues between the ages of 18 and 59. We are a state where we are our own state unit on aging. And we work with a terrific relationship with the Older Americans Act and with funding stream that comes through the ACL. Now, our major goal is to ensure the rights, safety, independence, and dignity of adults with disabilities and people who are aging. And we work very hard to prevent their abuse, neglect, and exploitation. And we have several programs that I will run through very quickly for you. But please know that one of the major programs that we have and we provide direct service delivery on is our Adult Protective Services program here at the state. And that's a very important measure to ensure the safety and well-being of older people. In addition, we administer the Choices for Independence 1915C waiver, which provides an array of services. And it is funded through our partners through CMS. Our Bureau works very closely with setting policy and program and implementation with our federal partners. And we've established a very strong relationship relative to our nursing facilities and working with them to make sure that we get individuals the choice they need to remain and age in the community, or when it is appropriate, and it is the individual's choice to enter a nursing facility for the right level of care. One of the things I do want to call your attention to is that we are an aging state. By the year 2030, it is estimated that over 1/3 of New Hampshire's population will be over 65 years of age. So our ability to move from transactional-based work within BEAS and to move to operational and to move to transformational, to prepare for this aging population is very, very important. And it's something that the department has been working with the State Commission on Aging with, and is part of our state plan on aging plan here in the state of New Hampshire. As I suggested, we have a wide array of services. The Bureau of Elderly and Adult Services manages 53 contracts. Throughout COVID, we have been able to amend many of those contracts because we have been fortunate to get funding from our federal partners to increase the service array to meet the needs during the COVID crisis. I I want to call attention to the terrific lifting that our nursing facilities have done. We have 71 nursing facilities, 11 which are operated by the counties. And during the COVID crisis, we all know that they were particularly hard hit, and the people that they support were particularly hard hit. Again, I'd like to call attention to the Adult Protective Services Program, which does a tremendous job acting as a safety net for individuals in our state. We also have the Service Link program, which provides for information and referral, as well as does Medicare counseling and works with veteran-directed home and community-based services as well. The wide array of other services that are listed here are delivered either through the CFI waiver or through social services block grants or through our Title III, Title 20 funding programs through the Administration for Community, Administration on Aging or Administration for Community Living. The Bureau of Developmental Services has a very, very similar mission, and that they are the state's designated agency to provide services for adults and children with developmental disabilities, acquired brain disorder, and in-home supports waiver. These are 3 1915C waivers that do the heavy, heavy lifting financially in partnership with our federal partners. We work very hard to ensure the rights, safety, interdependence, and dignity of adults with DD and acquired brain disorders, and we work very hard to prevent their abuse, neglect, and exploitation. We have a community-based service delivery system that is built on the core infrastructure of our area agencies. There are 10 throughout the state. They provide regional services in a protected catchment area. And they work very closely with providers. At this point in time, we have 70 providers that work with our area agencies. And there's a long established history of working collaboratively and cooperatively to ensure that we get the right supports to the people. Within the Bureau of Developmental Services, we also administer the Early Supports and Services Program. This is known as early intervention for children between the ages of 0 and 3. And the Bureau of Family Center Services provides oversight and management for that program, but again, very cooperatively done with our Bureau of Developmental Services. One of the biggest lifts we have as a Bureau is providing oversight for the waitlist management to ensure that people get services per RSA 171A. And we also work very hard to ensure that providers get paid in a timely manner and that we're very cognizant of our provider community and them being critical to making sure services are delivered. Again, the services are delivered through 3 waivers: the DD waiver, the acquired brain disorder waiver, the in-home support waiver. In addition to this, we also provide for forensic services. This particular year in the upcoming biennium budget, we will be closing our designated receiving facility for developmental services. And this provides an opportunity for us to partner with a third-party provider. We are in the process of procurement right now, so I can't speak any further to that. But please know that this would be the last closing chapter of the Laconia State School because the designated receiving facility is located up here. And forensic services will now be incorporated as part of a continuum of care. And we will be working very, very hard with this provider and with the area agencies to ensure a smooth transition moving forward. The Bureau of Family-Centered Services, again, is the Title V agency for the state of New Hampshire and works with children with special health care needs through the Special Medical Services Program, Family Support, and once again, Early Supports and Services. Again, a tremendous partner network where we work and provide and coordinate services assisting families, and everything is family-driven, family-focused, because we firmly believe that the parents have a great understanding for the needs of their children, and we are there to supplement and support those needs moving forward. It's a community-based system of care. It integrates public and private health services. And right now we are providing grant and contract management and oversight for 22 contracts and 3 federal grants within the Bureau of Family Centered Services. Again, 3 major focus areas with the Bureau of Family Centered Services. These include special medical services, family support, and again, early supports and services, Part C, early intervention. I want to talk a little bit about our priorities for SFY 22 and 23. Again, I cannot emphasize enough the import of the Alvarez and Marcel project work. This presents a tremendous opportunity to create a continuum of care that takes into consideration those with intensive treatment services. It brings individuals back to the state of New Hampshire. It gives us an opportunity to work with the area agencies who can work with families, who can get natural supports in place, and it increases our chances of transitioning people out of intensive treatment services in a group home setting to a less restrictive setting with good risk management plans. And this is a very, very important opportunity for those individuals who are placed out of state. I also believe that the tiered waiver approach presents an opportunity for equity. All 10 area agencies do heavy lifting. They all understand the needs of their families and their individuals. And we need to be able to provide them with the tools to make good equity decisions for the individuals that they serve. And working together over the next couple of years, I believe with good stakeholder input, we are going to be able to take this system to the next level. I would love to see us continue to fund BEAS home and community-based Choices for Independence program rate increases for case management, personal care services, and homemaker support. We had the opportunity to work with the case management agencies and a particular legislative group. I want to just call attention to the work that Senator Rosenwald brought to our attention. And we need to create parity in case management services. And the ability to raise the rate here allows us to ensure that somebody that reaches a nursing facility level of care has the important support of a case manager on weekends and has a monthly rate to do that, which would bring the CFI program for case management in alignment with the developmental services program. One of the areas that we are concerned about and that we see gaps in services is personal care services. We have put a rate increase in hopes that this will make a substantive difference in recruitment and retention. And the same goes for homemaker support, another area where we see an opportunity to help individuals stay in their homes and maintain a quality of life in their homes moving forward. I would recommend that we continue to suspend LTSS presumptive eligibility. And we would like to make sure that this language is inserted into HB2. Working with our federal partners, it is clear for waiver services, if we were to do presumptive eligibility, it would be 100% general funds and it would not be subject to match. And it could be burdensome in terms of a financial impact. And I quite frankly would like to see the dollars used to better support system transformation and other factors. Probably most importantly, I would like to continue to ask for the continued fully funding of the wait list per RSA 171A1A. The ability to support people and create transition plans for children as they exit the school system and into adult services keeps families whole, keeps parents working, and keeps an individual progressing towards independence based on their particular needs. And this is critical moving forward. In the end, if we were not to do that, we would see, quite frankly, probably a more expensive cost in the long run. And this is mission critical to the supports that we provide in the home and community-based setting for those with developmental disabilities.
Thank you. We have a question from Senator Hennessy.
Thank you. Deb, you had mentioned on the last slide, sorry, I don't have it in front of me, that you were able to raise rates. Were you able to do this without increasing the budget, or did you have the budgeted funds in your budget as well?
Thank you for the opportunity to clarify, Senator. Our request in the House phase was supported in terms of maintaining those rate increases. As you know, We had the 3.1% and the 3.1%. We need additional funding to be able to support appropriate delivery of those services, being case management, personal care services, and homemaker support. So that is currently included in the budget, and I want to make sure that it is maintained in this financial budget.
Can you tell me what page of the budget that is?
Yes. Okay. For the CFI rate increases, if you were to look at 506, which is home support waiver services, the case management rate increase is included there, as well as the personal care services amount. If you look at 529, that is home health care waiver services. That is the homemaker, and the increase for the rate is included in there.
Senator Rosenwald.
Thank you. Thank you, Mr. Chairman. I have a question about presumptive eligibility. It's my understanding there might be a change in federal law to make CFI and the entitlement along with nursing homes. And I'm wondering if that happened, whether presumptive eligibility for CFI would still have to be only general funds for that period prior to the determination.
Okay, so the legislation you're referring to, I believe, is the HCBIC Access Act, Home Community-Based Services Access Act. And that presents an incredible opportunity to establish home and community-based services as an entitlement, just as our state plan services are. At this point in time, I do not believe that there has been discussion to that level of detail, Senator Rosenwald, in terms of presumptive eligibility. So I don't think I could really take a hazard guess in terms of where that might land.
Okay, thank you.
Thank you. Further questions? And just a question on that page 506, what document is that?
Just to clarify, that is line 506. I believe it is page 1173 of the compare report, which has 505, 506, and 529.
Okay, thank you. Seeing no further questions, please continue.
I'm actually at the end and would welcome any questions that you might have in regards to the Division of Long-Term Support and Services.
Okay, great. Again, I see no, so I'm sorry. Oh, Senator Gaida has a question.
Thank you. And thank you, Deb, for taking my question. So I'm looking at the back page of your Division of Long-Term Supports and Services handout. I noticed just a really significant difference between the 22 and 23 governor's appropriations and the departments and the houses, I should say the house's appropriations. Is there some particular reason for that? I mean, that's a significant gap, huge gap.
Which line are you looking at?
I'm looking at under waiver and nursing facilities, you see general funds, 26 million, yeah.
So under statute, nursing facilities are paid for by county funds. And under current statute, there is a $5 million credit to the counties, which is essentially $5 million in general funds. So that is how the agency, DHHS, how I budgeted that accounting unit, which is accounting unit 2152 within that activity, which is the page number that was just mentioned a moment ago. In the governor's phase, they maintained that and kept it as the statute currently is. The House made adjustments to that and increased the general fund contribution, as well as made statutory changes, putting limits on how much county contribution there could be.
Thank you very much.
You're welcome.
Thank you. Seeing no more questions, thank you for your presentation.
Thank you.
Great, so we have economic and housing stability next. So I think Deb has a few people to bring over and a few people that can be released. and have a good weekend.
Thank you, you as well.
I was saying to them, we're all still here, right, for another hour.
Sorry? Oh. And Chris, are you going to be doing this presentation?
Yes, can you hear me?
Wait, very faintly.
Okay, I have my headset in. And let me try to increase the sound. Can you hear me now?
Your volume is way down.
Can you move the microphone any closer to your?
That's much
Maybe.
better.
It's like in my, can you hear me now? Let me try it without the speaker here. Okay. All right. Can you hear me now?
You're still very, very faint. See,
How's that?
much better.
Okay, so I'm gonna hold my laptop. So this should be an interesting presentation. And for some reason, my presentation just went away. So just if you give me 1 second, I am sorry that you have me end of the day on Friday. So I'm between you all and a weekend, and for that I apologize. So can you see? Okay, let me go ahead and share my screen here. Okay, can you see my screen?
Not yet.
Can you see it now?
Yes, we've got it.
Okay, so I'm just trying to, okay. All right. Maureen, I'm having an issue here. Are you seeing my notes too? Okay. I'm seeing a different version on mine for some strange reason.
Chris, why don't I go ahead and share?
Okay, that would be great. I'm having some difficulty here. Sorry about that.
That's okay.
For some strange reason, it was acting a little funky. So I'm going to go ahead and get started if that's okay. And while Karen's pulling up our slide, is that okay?
Sure. We do have the handouts anyway.
Okay, great. So my name is Chris Santinello. I am the Director of the Division of Economic and Housing Stability. And joining me today is Rebecca Lorden, our Finance Administrator for this division. Our mission is simple. It is to advance the health, economic, and social well-being of individuals, families, and communities. And it's our vision that individuals and families are strong, resilient, and thriving in their communities. Our division is broad, and we have, if you could go to the next slide, Karen, sorry. We have a number of programs, and our focus is really on upward economic mobility, helping families get out of poverty. Karen, can you advance to the next slide?
Oh, sorry.
Oh, that's okay. Thank you. And so we have our comprehensive family support programs, which support our family resource centers. We lead the preschool development grant in conjunction with the Department of Education through the University of New Hampshire. We have our Bureau of Family Assistance, the Bureau of Employment Supports. New Heights, our integrated eligibility system, is housed within our division. The Bureau of Child Support, Housing Supports, and Child Development and Head Start collaboration. Next slide, please, Karen. Sorry. Our scope is that we serve individuals and families from birth on through the lifespan. We provide a whole person, whole family approach. Our focus is really emphasizing the importance of the social determinants of health and its impact on a person and family, and the commissioner spoke about that earlier in her presentation. Again, we also want to focus on reducing programmatic and system barriers and silos to services. Oftentimes, our funding creates these silos. And when you look at it through the lens of a family, those silos really don't make sense from a family's perspective. We have a focus to strengthen program organization to improve quality and create solutions, and provide shared leadership in the commitment to integration and teamwork. Next slide, Karen. I'm going to slowly go over just high level what our different bureaus do, and then we'll kind of get into the budget impacts that Rebecca's going to share a little bit. Our Bureau of Family Assistance, that's our most of the services for this bureau are through our district offices, and this is where we assist individuals and families gain access to SNAP, medical coverage, our state supplemental programs, temporary assistance to needy families, and child care scholarship. This unit also sets policy and program implementation for the SNAP and TANF programs. And at the same time, we ensure access to all of the healthcare, nutritious food, childcare, and financial services to families that are eligible within our state. Next slide, please. Supporting individuals who receive assistance through the department, we have our Bureau of Employment Supports, and this assists individuals who are either enrolled in our TANF or SNAP programs with work requirements. Participants are provided case management, assessment, career planning, barrier reduction services in an effort to obtain and retain employment. We work with employers and educational training organizations to address labor market needs through training. And some of the work that we're actually doing is we're focusing some of our efforts in the long-term care. I know you asked Deb Sheets about workforce in her presentation, and we have had some meetings and started some work together with some of the area agencies as well as nursing homes as how do we partner so that individuals who are receiving TANF could potentially see careers in long-term care and also in child care. So we're really trying to work together with our programs to provide workers to assist with some of those workforce challenges. And this, within our Bureau of Employment Supports, this also leads the whole family's approach to job, parents working and children thriving. And some of this work is looking at the cliff effect, which I know Senator Rosenwald is familiar because she sits on our House Bill 4 Working Committee. But for families who are receiving public assistance, there's often disincentives for them to obtain a job or increase their hours within their job. And some of our work that we're doing to solve the cliff effect is how do we, instead of having a cliff, so if you're working and you take additional hours or go for a raise in a job, you might lose all of your childcare assistance. And in the end of the day, that doesn't help you or your family. And so we're working right now to understand what policies we need to change so that instead of having a cliff, it's an off-ramp as a way to incentivize people to work. So
Okay.
that's some of the work we're doing there.
And Senator Rosenwald has a question.
Great.
Thank you, Mr. Chairman. Thanks, Chris.
Yeah.
My question has to do with SNAP and also pandemic EBT. Are we taking advantage of all of the federal funding for our administrative costs? Because as I recall, for food stamps anyway, the state has to self-fund the admin costs. Are we taking advantage of everything? Because I noticed the caseloads are not as high as
So
one might
some
think
of the
they'd be.
SNAP caseloads early on in the pandemic, when the unemployment insurance counted towards eligibility, some people were no longer eligible for SNAP. And so we are working, lots of people apply. It's just, are they meeting the eligibility requirements? And our SNAP numbers were actually going down pre-pandemic and the use of SNAP. We did the pandemic EBT during the school year, and we recently submitted an updated pandemic EBT to Food and Nutrition Services at USDA. And it was submitted a couple of weeks ago, and we're just waiting approval on that.
Follow up, please.
Follow up?
Are you doing this only for school-age children or also for children under 6?
Right now, we're doing it for school-age children. It's really a complicated, pandemic EBT is complicated because it is tied to school children who are not in school 100%. And so it's really difficult to track some of that. So our first goal is to go ahead and do it for the school age and then look to see if it's a need for those under the age of 6. At the same time, we're also still providing the emergency allotments through SNAP, and we have been doing that since the start of the pandemic, since April of 2020.
Thank you.
Thank you. Please continue.
Great. Next slide, please. So our Bureau of Child Development and Head Start collaboration, this provides access for families to the New Hampshire Child Care Scholarship Program. It also provides support and customer services to child care providers. We really work closely to improve school readiness. So when children go to public school, they are ready to learn. And we engage parents in making informed choices. Our focus is on quality, and during the pandemic, and we're continuing to provide critical supports to stabilize the childcare industry. We all know that when the pandemic hit a year ago, when schools went remote, many people still needed to work, and childcare never closed. Childcare was essential to our state's economy, and so we provided a number of ways. To date, we've invested over $65 million of federal dollars to the childcare industry in an effort to stabilize them, so that when the economy fully reopens, childcare will be available. We are working very closely with New Hampshire Employment Security, as well as the Department of Business and Economic Affairs, and trying to make sure we match supply and demand, as that's critical to New Hampshire's recovery. One of the areas we're looking at with some of our new federal dollars through the American Rescue Plan is, how do we align supply and demand when you think about tourism and retail for New Hampshire's economy? How do we match the need for nights, weekend, off hours care with the available childcare that availability that we have? And so we're doing a lot of work around that, and we're hoping that through some of these federal dollars, we'll be able to enhance family childcare as one of our plans, as well as partnering with businesses differently. Next slide.
Thank you, Mr. Chairman. Chris,
Yep.
Chris, tell me about the process of your integration with Head Start and Early Head.
I'm having a hard time hearing you.
Okay, how are you working with Head Start and
Oh,
Early Head
sure.
Start and Early Head Start? And are those kids actually getting to the locations now? Are
So
they
many of
filling
them-
the slots?
Yeah, many of them are, and we worked really closely with the Head Starts. You know, those are through the CAP agencies, and so
Right.
a number of the CAP agencies, when the programs were closed last year, you know, they still did outreach to the families, and a number of our CAP agencies that provide early Head Start and Head Start, they also provide childcare, and so through our child care scholarship, so they figure out the best way to wrap around the families and provide them the services. The program sites were closed, but some of the services never stopped. And so
Right.
the CAP agencies worked really closely to try to provide those services, you know, in the community and other places where the families were.
And further questions? And what kind of numbers are involved in that program?
So I don't have those numbers handy. I can get you those numbers. After this, I can follow up with my staff in that area. I don't have them off the top of my hand.
Okay, thank you. Thank you, Mr. Chairman.
Thank you. Senator Gaida.
Thank you, Mr. Chairman. Chris, sort of an aside, but in these childhood programs, are there recommendations to parents about diet, given the explosion of childhood obesity that's plaguing our schools and our young people?
So that wouldn't, some through some childcare centers, they may do that. Also, more of that would be done also through our family resource centers and other areas that provide early childhood access, our home visiting programs, and all of that.
Thank you. Please continue.
Great. We can go to the next slide, please. So our Bureau of Housing Supports, I know that there was questions about that earlier also in Deb Sheets' slide deck. So what we do here is we really assist individuals or families who are have housing instability or homelessness to access housing, shelter, and other services to assist in achieving or maintaining housing stability. So a couple of ways we do that. We provide short-term and medium-term rental assistance and permanent supportive housing. We do a lot of outreach services, and I'll talk a little bit about how some of that's expanded. We provide case management services, and we're also the collaborative applicant for the Balance of State Continuum of Care. New Hampshire has 3 separate continuums of care. We have the Balance of State, we have Greater Nashua, and the Manchester Continuum of Care, and the department serves as the collaborative applicant for the Balance of State. One of the difficulties we face, and I think Senator Gaida, you asked about it in when Deb Sheets was speaking, is the lack of available housing. Right now, New Hampshire has a vacancy rate of 1.8%. For apartments, and that's not a healthy vacancy rate. I believe New Hampshire Housing Finance Authority in their last report estimated that we needed about 20,000 more units just to meet our current demand. And so because of that, it makes it really difficult for homeless shelters to actually have people exit to permanent supportive housing. When we had additional COVID funds that were given to the state, about $8 million to support individuals experiencing homelessness, our first reaction was, great, let's put some of this money into rapid rehousing, so to get people into housing. But the problem is there's not enough housing stock. So instead, we had to provide additional funding for shelters so that they could continue to house people meeting socially distanced requirements. So in November of 2020, Governor Sununu created the Council on Housing Stability. And really what this council's looking at, it's a cross-sector membership, and there's about 41 appointed members, and then we have 4 work groups that include about 80 different people with an interest, is really looking at what is needed, not just to solve homelessness, because we all know housing ends homelessness, but how do we look at ways to create greater housing stock and greater housing availability in our state. And so the council right now is really looking at what needs to take place and what recommendations they have, and we'll be finalizing that next month, or actually in June, with some recommendations. But we're looking at, what kind of regulations need to be proposed. Are there ways we can actually utilize businesses, vacant business space differently for housing, and supporting supportive services to help people obtain and maintain their housing. New Hampshire is very close to submitting a state plan amendment under Medicaid for supportive services. We are close to the draft being done and submitted again to CMS. We're also looking at what type of case management needs to take place across a person's lifespan to ensure housing stability.
Senator Rosenwald, did you have a question?
Nope, I put my hand down. Thank you.
Okay, thank you.
Great. Anything else on this one?
No,
Okay.
please continue.
Great. Our Bureau of Child Support Services provides statewide services to families of children who do not reside in the same household. We encourage responsible parenting, family self-sufficiency, and child well-being by providing services to locate parents, establish paternity, and modify and enforce support obligations. We assist and we engage and assist parents who are willing or unwilling to support their children. And each year we process over $80 million in private funds to families, which lessens the need for governmental financial assistance. Next slide, please. Just quickly, I mentioned our New Heights system. This is actually our IT system that is for integrated eligibility. We actually have one of the only integrated eligibility systems in the country, which is great because when a person comes into the department or through our online portal, New Hampshire Easy, they can apply for Medicaid, SNAP, TANF, childcare, and state supplemental programs without having to go into multiple doors or speak with multiple staff. So we have our New Heights, which actually processes all of our eligibility, and then New Hampshire Easy Gateway to Services is our online portal where people can apply online. And we've actually seen increased numbers of people using New Hampshire Easy during the pandemic. We've done a significant amount of outreach to encourage people to use New Hampshire Easy to get access to their account. So that's been really positive. Next slide, please. Our family support services, we actually provide through the Division of Economic and Housing Stability comprehensive family support services. And that is really a prevention program for families who are at risk or need additional assistance with parenting. And our ultimate goal with comprehensive family support is to provide primary prevention so families do not become involved with the Division for Children, Youth, and Families. Our focus is on increasing child well-being, family strengthening, and we provide parenting, education, home visiting, social supports, parent education, play groups, lots of ways to keep families connected. And we actually track families once they exit the comprehensive family support program to see if those families end up needing services through DCYF. And in our last year, we tracked families for 3 years. And in our graduating class of 2000, my math is all off, 18 or 2017, 89% of those families in 2020 did not become involved with DCYF. So it's a really positive program that works really closely with our communities to meet the needs that communities face to supporting families. Tied closely to comprehensive family supports are family resource centers, which are independent nonprofit organizations, and they are provided throughout the state and really meet the unique strengths and needs of each community. And they are a hub for families to go to get information, parenting education. A lot of the family resource centers are really the link that families go to in their communities when they need assistance. We have a contract with the New Hampshire Children's Trust to provide facilitating organization services to the family resource centers, because many of the family resource centers are small organizations. They rely on volunteers. They have really small budgets. And what the Children's Trust has been able to do is provide infrastructure support in an effort to strengthen our family resource services. They also administer and manage our kinship navigation program, which provides support to relative caregivers to care for their family members. Next slide, please. Some of our challenges for this next biennium is funding for the New Hampshire Children's Trust that was not included in the budget. So it's $320,000 of general funds each year, but they provide critical work to strengthen and support our family resource centers. Without that support, it makes it really difficult for us to increase family strengthening and child well-being, and the families that need those supports, you know, without the services and the infrastructure of the family resource centers, they will end up being involved in the Division for Children, Youth, and Family. The family resource centers will be critical as we start to come out of COVID and all of the COVID benefits that families are receiving, such as additional Medicaid assistance and additional SNAP dollars.
And Chris, that one is 325,000 a year.
What did I say?
350.
Oh, sorry. Oops. At least I didn't say million. So, you know, sorry about that. For our child development and Head Start collaboration, there is not adequate funds to provide, protect, and prevent childcare. This childcare is provided to children who are involved with DCYF or those that are involved with the Comprehensive Family Support Program, but need quality childcare to assist their families. And so we need additional funds to help cover, protect, and prevent childcare. Our Bureau of Housing supports, we have included in our prioritized needs funding to assist shelters. Right now, we reimburse shelters at about $8 a day. And the cost to operate a shelter is about $40 a day. So we really need to try to close that gap to meet the needs of individuals and families experiencing homelessness. And then we need some additional general funds to help us meet our TANF maintenance of effort, because we have a general fund requirement to access our federal dollars. And we are and then the next slides, Rebecca is going to talk a little bit about the budget pieces for our division in these areas.
And have Senator Hennessy with a question.
Yep.
Thank you. Can you, under the Bureau of Housing Supports, can you tell me what the state's responsibility is and what local municipalities' responsibilities are for the housing needs of their citizens, residents?
So we provide services within our funding for shelter services, and those are 100% general funds. And then we have some federal dollars that assist people with supportive housing and permanent supportive housing. At the end of the day, and I'm going to look at Karen because she knows this probably even better than I do, if a person is in a city or town and they need, and they're homeless, it is under RSA, I think it's 167A, that the town and city has the responsibility to help the person with housing for a period of time until they can get connected to services.
Follow up?
We try to work, our goal is to work really closely with communities to meet the needs, but our Bureau doesn't provide the housing stock. We just provide the services that help people to maintain and obtain their housing.
It's just a follow-up. So
Yep.
your Bureau doesn't actually pay for the housing? They pay for the people that help find housing?
We would help somebody with short-term permanent supporting assistance and services. But if you need a housing voucher, that would be through New Hampshire Housing Finance Authority. We provide eviction prevention dollars. We also provide permanent supportive housing, which we have in limited in limited numbers. But if you are somebody who needs assistance with your rent, like a Section 8 voucher, that's done through the public housing authorities.
Thank you.
Senator Rosenwald.
Thank you, Mr. Chairman. Karen and Chris, I think you told us that the cost of the Children's Trust was $325,000 a year. Will you be able to provide us with numbers for the other three prioritized needs that you list here?
Yes, so they are actually all on that summary document that I provided with the OCON presentation. And so you should find the corresponding numbers. What I can do is on the last slide here, it lists each of them, and I will get you the number that corresponds with on the summary document.
Thank you.
You're welcome.
Thank you. Are there further questions? One of the questions I would have, Chris, on benefits that you hand out, like on housing assistance, is there any requirement that somebody be looking for work? Because it seems though in a lot of cases, if somebody had a job, then they wouldn't need the services from the state.
So we provide some short-term and medium-term rental assistance. And so our rental assistance is time limited. And then we work with other programs to help people access to get jobs, to do other things so that they don't need this assistance. So it's short term. One of the difficulties we have actually though is in our in the shelters, there's actually a high number of people who are employed living in shelters. They just can't find apartments to live in that they can afford. So there are a high number of people that are working, and I don't have that data handy, but I do have it in our data system, and I can actually provide that for you, that are working. And we can provide people with, what they need for their first month's rent, their security deposit. They just can't find the actual apartments and housing.
Okay, and I understand that. So talking about the ones that are not employed, understand we have a housing, but you're working with employment security. And, the question is, are we, for those that are not employed, are we putting any kind of an incentive for them to be looking for work?
So we work really closely. Lots of times people who are experiencing chronic homelessness have mental health concerns, substance use disorders. And so we work really closely with the other programs to help people to obtain and maintain their housing as well as their job employment so that they don't need the assistance. And we work really closely to use our funds for a period of time and then work with people so they can access other funding and other programs outside of our state programs, such as the Section 8 vouchers and that come to assist people with their housing needs.
Okay, thank you.
You're welcome.
Seeing no further questions. Is that you at the end?
I think I am at the end.
Okay. So that, I guess that concludes our business for the day. Thank you very much for your presentation. And the committee will be meeting at, I believe it's 12:30 on Monday to continue on Health and Human Services. So with that, I will take a motion to adjourn.
So moved.
Moved by Senator Gaida, seconded by Senator Hennessy. We'll call roll. Senator Morse. Senator Gaida.
Yes.
Senator D'Alessandro.
Yes.
Senator Hennessy.
Yes.
Senator Rosenwald.
Yes.
The chair votes yes, and we will be adjourned. Senator Reagan is excused. And thank you very much, and we'll see you on Monday. Have a great weekend.
Thank you.